you should see good pulsatile flow. Then usually you will retract the device outside the vessel so you see cessation of that flow, and then advance a couple of millimeters in to see blood flow again. The point of that is to avoid catching the posterior wall of the vessel, and so you get a good deployment of the sutures. So once you're confident that the perclosed device is in the vessel, you then deploy the device, the 2 sutures will go down. That's after you've turned it a little bit at an angle so that it's around 10 o'clock. That's sort of shown in this diagram here. After the device is deployed, you remove the slack from the suture, sort of pull it in the direction of the vessel, and then tack it to the drape. So that diagram just shows the delivery of the first perclose. After that, you remove that device, and then a second perclose is then inserted into the vessel in the same way. This one is turned 90 degrees from the position of the first device, and then in the same way, the sutures are deployed, and again, both the lock line and the other line are pulled back in the direction of the vessel and tacked to the drape. You want to be careful not to prematurely lock the knot, which is done by accidentally putting on the white string. So here now you have 2 percloses that are deployed in that X-like fashion. Then you sort of, go on to the main procedure and deploying the valve, and then this is just showing what we do after valve deployment when you're ready to take out the big sheath. So here, this is the crossover balloon technique, where we take a balloon that is sized to the external iliac artery, usually about 8 or 10 millimeters, and that's advanced over the 014 wire that's down the main access SFA. We then withdraw the large sheath into the common iliac and advance the balloon over the aortoiliac bifurcation. And here you're still maintaining access through the large sheath with a 035J wire. We then withdraw the sheath to about 2 centimeters above the arteriotomy site and advance the balloon at the same time. And then you do a small injection with contrast through the lumen of the balloon just to verify that there's no arterial injury. If you do see any injury at that point, you can inflate the balloon to help tampen down the bleeding. At this point, the balloon's inflated just proximal to the sheath and flow is occluded. And then the sheath is removed with the balloon up, and you deliver both of the knots of the perclosed devices. At this point, you really shouldn't see any bleeding because the balloon is still occlusive, but then deflate the balloon and again make sure that there's adequate hemostasis. If you do see bleeding then since you still have the ipsilateral J wire in place, it's possible to deploy a third perclosed device, and this is usually done straight up and down. And then if you don't see any bleeding, then it's fine to remove the J wire and just lock down the knots and cut the sutures. We always do a completion angiogram at the end of each case. This is not the same patient. You can see this is the right side. But here we just want to make sure that there's no extravasation of contrast and that you don't have any pseudoaneurysm or anything like that. If there is some bleeding that you're worried about, it's always an option when possible to give protamine to reverse the anticoagulation. And it's always a good idea to, even if you don't see any bleeding, hold gentle pressure for at least 10 minutes. More and more of these cases, as Dr. Leon mentioned, are done awake in sort of the minimalist approach. But for patients who are intubated, it's important to hold pressure during extubation because often when they come off of the ventilator, they buck the vent and sort of increase their intra-abdominal pressure, and you can get a lot of bleeding at that time. Also, just for patient comfort, it's nice to give some more long-acting local anesthetic. Usually we use bupivacaine. So I'll just show a couple of examples of access site complications. So this is, here you can see access site bleeding after closure. There's a lot of extravasation of contrast here at the site of the common femoral. This can be resolved just with balloon tamponade. So that balloon that we used before is advanced to the site of the bleeding and then inflated. And it can often take a few minutes to resolve. But in this case, you can see here that there's still a small pseudoaneurysm here, but otherwise the bleeding that you saw previously has stopped. This is another example, sort of a more severe example of retroperitoneal bleeding after closure. Often these cases require a covered stent, and so the most important thing here is to obtain control of the bleeding with a occlusive balloon while you're able to sort of get all the equipment that you need in order to put the covered stent in. These aren't sort of stents or other wires and things that we use commonly. And so it's just important to make sure that you have everything available while the balloon is up, because once the balloon is down, you need to deliver all the equipment quickly. In this case, the balloon was inflated at the arteriotomy site to gain control, and then the coronary wire, the 014 wire, was exchanged for a supercore through the balloon lumen, and then a covered stent was deployed using fluoroscopic landmarks. You want to sort of be careful not to cover the branches or the profunda, if possible. Here's a case of an occlusive dissection after the large sheath was removed. In this case, again, if you advance the crossover balloon to the arteriotomy and just inflate it at low pressure for 1 or 2 minutes, you can tack up the dissection planes. If that doesn't work, then the next step would be to consider putting in a self-expanding stent. And then lastly, thankfully, this is something that I haven't witnessed, but a more sort of catastrophic complication is iliac rupture. And again, the most important thing here is gaining control and then sort of having the expertise and the equipment in the room that you need. It can be managed percutaneously, and in this case, a balloon was occluded proximally, and then a covered sheath was placed over the ipsilateral wire on the same main access side, and the sheath was then removed, and the perclosed sutures were delivered with a pretty good result here. So just sort of in conclusion, the advantages of using a crossover balloon are that you always have a wire in the true lumen, that you're able to have proximal control of any bleeding in case it occurs, and that you can use that wire for percutaneous treatment of any sort of complication that may arise. The disadvantages are that it does add one extra step to the procedure and sort of the time and equipment associated with that, and also the cost of the equipment that you would use. Percutaneous closure can be performed with pretty high rates of success using the existing equipment with the 2 perclosed devices and careful attention to vascular access at the beginning of the case. When it fails, balloon inclusion is a pretty good strategy in order to manage the most commonly seen complications of bleeding, perforation, dissection. But it is important in the more serious cases to have the proper equipment and personnel available. Thank you.
Great. Thanks, Amisha. It's a wonderful talk. And I think one thing I forgot to mention when I was introducing Amisha is that Amisha has close ties to Hyderabad and Srinivas. She has gotten a grant and is doing a screening of asymptomatic pregnant women for valvular heart disease in government hospitals in Hyderabad and surrounding regions. And so she and Srinivas have set up this program. They found women that were asymptomatic, had significant valvular heart disease during pregnancy, and has managed to arrange for treatment for some of these some patients as well. So it's a great program, and I wanted to sort of highlight that because I think it's really quite remarkable in what they've done over the last 3 years. And with the support of Edwards, they actually had gotten a grant from them. So I wanted to sort of mention that before I forget. But going back to this talk, I just want to ask a question to the Indian colleagues. When we started doing TAVR, it was larger sheets, and but we also did all of our coronaries from a femoral approach. In India, where most of the training is radial, and I would say you're 95% radial, what do you do to get femoral experience? And is that a problem when sites are starting to do TAVR, when they don't do a lot of coronaries from a peripheral approach?
Yeah.
I don't know.
So let me answer this first.
Yes.
Sai can also chip in. So basically, when I started my training, it was mainly femoral only. So we are basically femoral trained people, and now for the last 10 years. So most of the times, the people who are doing TAVR are actually trained in femoral 99%. I don't know, Satish. Satish looks very, very young, so I can't really guess his age. but maybe that he started a little later. And so he was more trained in radials.
He's young at heart, though.
No, he's young as well.
I'm a hardcore federalist, Dr. Chabra.
So there's no problem for us. Yeah.
So, I mean, for the junior people there, I mean, they're almost all radial, right? The people that are training now, is that it is one of the concerns that I have for junior people starting.
Absolutely correct, because they have not seen the usual complications of femoral routine percutaneous interventions, which do happen, like dissections, vessel occlusions, and perforations. They also happen even with 7-8 French sheaths sometimes, and we used to manage that, and then that was the learning process, and that is very handy when you are dealing with these complications. But certainly, with all this exchange of information and a lot of all this presentations, most of them are getting well versed with this, and I'm sure with increasing more, because we don't have that much experience of 100,000 or 200,000 valves. Here we have, I think, reached maybe 4,000 or 5,000 valves only in India. So everybody is progressing slowly, and I think everybody will catch up.
Sai, do you cross over with a wire in every case, or do you?
So I used to, Sushil, but now 95% of my sticks are ultrasound guided sticks. What I've had so many complications with, being with Dr. Matthew, starting off my entire coronary practice, I'm still 99% femoral. You have to beat me with a stick to go radially, right? So, and the Perclos and the Angioseal came almost 10 years back in India. So we've been so comfortable using them for a long time. But I used to always have a crossover wire and a balloon initially. But once I learned ultrasound guided puncture, I think it should be the gold standard, Sushil, because you will always get an anterior stick. You can avoid the plaques. Your Perclos failure rate is almost abolished. You know you're not retroperitoneal. Tremendous advantages. The micropuncture needle you use is more sound visible than the other needle. It doesn't have a bevel, so the shear on the vessel is less. So it's just a no-brainer.
That's great. No, I think it's a great thing for people to start. And I think the crossover wire is not necessary. We don't use the balloon in every case, but we still put a wire because it helps train the fellows as well. Because I think just the techniques, how to manage complications are much better if you know how to cross over and get support and things like that. And also early on in experience, I think it's always good to have a backup plan.
Absolutely.
So we'll move on to our next speaker. Who's going to be needs no introduction. As I said in the first talk, Dr. Grube has along with Marty, have been the two sort of instrumental leaders, along with Alain Cribier, in moving this field forward. He's going to give us his perspective on bicuspid valves and TAVR.
Thank you very much, Sushil. I just try to share my talk. Can you see it yet?
We can see your slides.
Oh, you can?
Yeah.
Okay, that's perfect. So thank you very much again for having me. And I'm really glad, even though I am quite intimidated, having Sushil here and Raj Makar on the panel talk about bicuspid aortic valves, but I will try to do my very best to fulfill my task and talk a little bit about my perspective or my summary on bicuspid aortic valve. And since I'm in the age group of Marty, obviously my disclosures are a little bit more than the younger ones. And again, I would like, to give credit to this wonderful man. All of us, he inspired all of us. But I'm mentioning this because he started this journey 2002 with a calcified bicuspid valve. So very appropriately, I would give my honors and my sympathy to Alan, who did this patient 2002 with a bicuspid valve. The other thing that I couldn't resist is this. Secretary Rumsfeld did something that I think is so nice for bicuspid valve. There are known knowns. There are things we know. We also know there are some known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns, the ones we don't know. So putting this into the bicuspid valve, Let us start with the known knowns for bicuspid valve. First of all, BAV, bicuspid aortic valve stenosis, is a frequent disease in the general population and in TAVI patients with some geographic differences. Bicuspid AS will be encountered with greater frequency as TAVI moves into younger patients. Anatomic features of bicuspid aortic stenosis are, in fact, unfavorable for TAVI. Bicuspid aortic stenosis is not included in any of the pivotal trials. No randomized data exists as of now. And TAVI is approved for bicuspid aortic stenosis. And finally, clinical outcomes are comparable between tricuspid aortic stenosis and bicuspid aortic stenosis patients when using second-generation valves. Continuing with the known knowns, BAV is a frequent disease in the general population and in TAVI patients with some geographic differences. We all know this, not much to be said. TAVI is prevalent in the younger age groups, 50, 70, 69, and 60%. If we move into the older generation, then obviously the bicuspid morphology becomes less. And this is also the frequency of bicuspid aortic stenosis in TAVI registry overall. And look at the geographic differences as an example in China and to some extent also in Japan. But here, 59.3% with a mean age of 74. So there are many, many differences, and we learned a lot from our Chinese colleagues. Another known anatomic features of bicuspid aortic stenosis are unfavorable for TAVI. There is the BAV classification of Sievers. We know, pointing out to no raphe, one raphe, and two raphes, and also a slight modification of that Sievers classification is an anatomic classification of bicuspid aortic valves based on a study of surgical specimen. The two prominent black lines denote the raphe, and this is the American Heart Association classification. Basically the same, slightly more different. And then the Gilayavi CT classification, basically focusing on tricommercial and bicommercial raphe and non-raphe types, and whether you have calcifications or not. What are the concerns of bicuspid aortic stenosis in TAVR or with TAVR? Calcium, calcium, calcium. But there are also anatomical and procedural concerns. Annular eccentricity, asymmetric heavy valve calcifications, usually unequally sized leaflets, calcified raphes, concomitant aortopathy, lack of standardized annulus measurements. Procedural concerns, elliptical deployment, impaired bioprosthesis durability, residual aortic regurgitation, annulus rupture, coronary obstruction, and aortic complications. Next, known knowns, bicuspid aortic stenosis is not included in any of the pivotal trials, no randomized data. 14 years of trial, 10 trials, close to 10,000 patients, 8,000 patients randomized, and no patient with a bicuspid aortic stenosis. Next, TAVI is approved for bicuspid aortic stenosis. So if you use it, TAVR is not off-label use. And finally, clinical outcomes are comparable between tricuspid aortic valves and bicuspid aortic valve patients when using second-generation TAVIs. And here is the second-generation devices, S3 Evolut, Lotus, and Actuate Neo. And you can see here the S3 and Evolut are in a meta-analysis published in 2018 of 13 observational studies. And you can see here, these new devices bring down the paravalvular leak percentage and also, thank God, the pacemaker rates as shown in the Evolut and partner trials. This is contemporary TAVI for bicuspid and tricuspid, looking at the STS ACC TVT registry. And you can see here, 81,000 patients, close to 3,000 bicuspids, propensity score matched. There's no difference in mortality at 30 days and at 1 year, though the 30-day stroke rate is higher in bicuspids, 2.5 versus 1.6. And looking here at the latest communications from STS ACC, looking at the SAPIEN 3 data and the Evolut R data, 1-year mortality stroke, basically you can see the same between the two types, bicuspid, tricuspid, and the same is true for Evolut. So now we switch gear to the known unknowns, which are the high-risk features for bicuspid aortic stenosis that preclude TAVR. The sizing methodology, which valve is optimal, and results of an FO randomized trial. And I think this is a wonderful example of this 75-year-old patient with bicuspid valve. Very practical issues. Is this patient feasible for TAVR? Which type of valves could we use? How to select the optimal size? Should we do pre and post ballooning? Is there a device under expansion? And is there an associated aortopathy? Which are the high-risk features of bicuspid aortic stenosis that preclude TAVR? You can see here, and Raj Makar and his group summarized this beautifully at PCR 2019, bicuspid aortic stenosis, looking at the CT, no raphe, non-calcified raphe, and calcified raphe. Could be done. These are more difficult. Anything in between is questionable. So that's something that we have to keep in mind, but CT is there. And then, of course, the aortopathy, higher risk surgical and very old age, obviously go to TAVR, even in the bicuspid patient population. But if it goes into lower surgical risks with various concepts of the aortic root and ascending aorta size, you might actually go to surgery if you have to include aortic surgery. If it is not associated with any pathology of the aorta, you might consider TAVI as indicated. The next known unknowns are reading those three: sizing, which valves optimal, and randomized controlled trial. And this is an ongoing issue here. Sizing for bicuspid aortic valve. And this is a very nice summary of what's happening in bicuspids. Asymmetric anatomy might lead to annulus orifice mismatch, which eventually might lead to non-circular and inadequate expansion of the stents and impaired valve durability. That leads to possibly incorrect valve sizing, which incomplete acquisition, migration, eventually then leading to paravalvular leaks, and then you have the problem with aggressive post-dilatation, or you end up with a valve-in-valve procedure. Various sizing methodologies have been proposed for TAVI in BAV: annular sizing, supraannular sizing, 4, 8, 12 even, and of course the balloon sizing. This is the, let me just change this a little bit. This is the sizing method of the Bavard study published by Didier Chiche, and you can see the Bavard study found that annulus sizing based on the annulus is applicable to 88% of bicuspid patients. And only a tapered anatomy may actually have an advantage if you take intercommissural distance, or ICD, into account. So 88% apply to this, and the remaining 12% maybe to the tapered approach. I do have a problem, though, with that. They conclude prosthesis under expansion is constantly observed in BAV based on annular sizing, and annular-based sizing is accurate in bicuspid aortic with minimal oversizing. So there's something there that I don't like, or we should keep in mind that using annular-based sizing, you end up with an under-expansion of the valve. The CT scroll technique, I believe, is very, very elegant. And mid-systole, you can identify, or you have to identify the basal annular plane and slowly scroll up and down from the annulus to above the sinuses of Valsalva. Examination of the images can identify the following: location and morphology of the cusps and leaflets, presence of any raphe between the leaflets, extent and distribution of calcium, and the location of the coronary arteries and size and shape of the supraannular effective orifice area. Very, very good technique. So how do I do it? We know sizing until today is still empiric. Annulus and intercommissural diameters have to be taken into account, particularly for conic configurations. I do select the smaller ones. If in doubt, I use balloon sizing. I take a look at the calcium amount and its distribution. The ascending aorta evaluation is mandatory in order to really say, is TAVR enough, or does this patient needs additional surgery of the ascending aorta? Ascending oversizing should be minimal in balloon expandable valves, and obviously no oversizing in self-expanding valves. And if you decide to do, careful post-dilatation if necessary. And finally, we come to the unknown unknowns. How many patients will continue to need surgery if a randomized controlled trial of TAVR versus SAVR will ever get done? Who with bicuspid aortic stenosis will still get surgery versus TAVR? Very young patients, significant aortopathy, 25% of the younger patients have that, hostile LVOT calcium, anatomic exclusions such as slow coronary arteries and anomalous coronary arteries, and then possibly unicuspid valves. Now, the randomized trial, I know Raj on the panel, so definitely there are pros and cons. I don't want to summarize that, but the randomized data comparing surgery and TAVR are still lacking. Propensity score matching analyses suggest similar rates of mortality between therapies. And if we look at TAVI versus surgery in bicuspid aortic valves in a propensity match study recently published here, you see 4,000 patients in the US show similar early safety and clinical outcomes between the two approaches. And all-cause mortality out to 2 years did not differ significantly. The same study, similar 30-day mortality, stroke, heart failure rates for TAVI and surgery. Surgical patients had more respiratory complications, new onset atrial fibrillation, and acute renal failure. And TAVR patients had higher incidence of new pacemaker implantations. So my last two slides then, in summary, TAVR is approved for bicuspid aortic stenosis without randomized data. There is a decent amount of experience with TAVR in bicuspid aortic stenosis that we have some idea of who will do well and who won't. Some patients will clearly need to stay with surgery. A randomized controlled trial will likely never get done. And never forget, post-implantation views in bicuspid aortic stenosis always have a look at the two opposite projection. In LAO, this looks quite nice. And in RAO, you see what is happening. If you have to fiddle a wire through this thing, it becomes very, very difficult. Never forget. So, take-home message, TAVI techniques for bicuspid valves. CT sizing is gold standard, but still empiric. Always pre-dilate, take the minor diameter of the annulus. High implants remaining across the annulus if possible. Assess stent frame expansion in two orthogonal views. Post-dilate if necessary. Minor annular diameter, mean derived diameter. And systemic use of cerebral protection devices is questionable, although I would recommend, because all the data that we have, based on the calcification and on the valves and post-dilatation as well as pre-dilatation, I would use cerebral protection in all those cases. Thank you very much for your kind attention. And again, thank you for having me with you again.
Rohar, that was magnificent overview. It was brilliant, and you know, you sort of highlight a lot of the concerns.
I lost you.
Oh, can you hear me, Eberhard?
I can hear you, but I can't see you. But now, yeah, okay, there you are.
Yeah, no, I was just saying that was a brilliant overview.
I don't know what's happening with you.
You got a haircut. No, but I think is a brilliant overview of sort of a lot of the issues in a very systematic way. Sai and Praveen, you guys, you're sort of on the same, almost not, maybe not as high as China, but the amount of bicuspids you do in India are a lot more than we see in the US. How are you, is it giving you pause? Are you just going ahead? Device versus device? What are the thoughts in India and how are people approaching it? Maybe each of you can make a quick comment.
Yeah, Satish, yeah.
So if I were to turn down bicuspids, I wouldn't do TAVRs in India at all. Yeah. 2 out of 3 of my cases are bicuspids. I am terribly biased towards the self-expanding platform. So for me, that's my preferred device. And there's only one question. I mean, Dr. Grube, your talks never cease to amaze me. I mean, the lucidity with which your brain puts things forward is fabulous. There's only one question I have. How the hell did the nose cone come out of that last TAVR?
It was a patient that I did, and I'm glad you're asking this, which tells me 2 things. Number 1, you're paying attention, which is good for me. Number 2, you are very experienced. And number 3, that was one of the early ones. And I remember this case. It was very, very dramatic. I was proctoring in south of Brazil, and we didn't have very much experience. And at that time, we used CoreValve, and it looked so good and so nice. I said everything is good, and then we know there was a leak, and then we changed, and I said, "Oh my God!" And to be honest, what I did. I used a little balloon, in order to not get caught by the struts of the frame. So that's why I'm saying it turns a very easy procedure into a more complex procedure, difficult procedure, if you don't pay attention. That's why, actually, because I looked at the agenda and I thought I had 15 minutes, but then I looked at 12 minutes. I wanted to share a catastrophic case that Sushil was kind enough to provide with me. He got out of this beautifully, but this is probably what we can tell the younger ones. Don't make the same mistakes that we do, and certainly not pull the wire in a secure position before you have 2 opposite views, and then you see what's happening.
Absolutely.
Excellent. Praveen, any other?
What do you think? Yeah. I remember your room there when we had the tea session. What do you think about this? Praveen?
Yeah. Hello. How are you? So it was wonderful to hear you again. And as Sai said, that this was fabulous, ideas, very well put together. I can't, find better speaking people than, you and Dr. Leon. Anyway. So now the thing is that for bicuspid valves, the points you actually pointed out were absolutely, very, very practical. And I have seen personally a few patients, because we do a lot of bicuspid here, as you already know, that 40-50% are bicuspid valves. And in some of the patients where the calcification was very high, it is extremely, almost impossible to get away with the leak, because the valve doesn't expand. We tried even valve in valve. We tried all sorts of things. And I'm glad Saurabh is here. And Saurabh Saurabh knows about one of these cases. Saurabh.
So, I'm just dreading after these 2 wonderful talks. I already made a note to myself, never ever accept an invitation to follow Marty and Eberhard. So Sushil and Sridhar, thank you for that.
On that note, so our next speaker is a friend, Dr. Saurabh Gupta, who's going to talk about a different anatomical subset that we're seeing more and more about TAVR as a bailout for surgical valve failure, or TAVR valve failure, a valve and valve. So Saurabh, you want to go through your
Absolutely. I think I need to share my screen. So there we go. Does that project, Sushil?
Yeah, yes, perfect. We can see you perfectly.
Okay. So my first disclosure is that whatever I do wrong, it is because of Sushil, since he proctored me for my first case like a decade ago. and then I had to get him drunk with some nice Portland beer. Do you remember that, Sushil?
O que está acontecendo?
Okay, I think Everhard might need to just mute. So these are my disclosures. The only two significant ones are I'm a consultant and proctor for both Edwards and Medtronic, but they don't apply to this talk. So my topic today is valve-in-valve TAVR. This is really interesting and evolving area similar to bicuspid aortic valves. Certainly, this has been widely adopted to treat patients with failed surgical prosthesis. And I would say that with careful pre-planning, this could be done very safely and with minimal procedural complications. Now, the short-term data for these are excellent. This, for example, is from TCT, 30-day outcomes in a self-expanding valve. You can see that at 30 days, the all-cause mortality is very, very low. The need for pacemakers is very low. And with evolution in vascular access management techniques that Amisha so elegantly presented, all of those complications are quite low. To the point that in the ACC guidelines then for both prosthetic valve stenosis as well as prosthetic valve regurgitation, a transcatheter valve-in-valve procedure is indicated. And certainly in our practice and in most practices, I would say, has become the de facto standard of care. Now, when you look at the data from the TVT registry, we know that this is quite safe. We know that the procedural times are quite low. The risks of anything more than mild paravalvular leaks are quite low. However, one thing that I'm sure is not news to this audience, that the gradients are elevated compared to native valve TAVR. And that makes sense. And we'll spend some time towards the end, if I still have time left over, to figure out what implications that has, and then perhaps poll the panel on how we think that we can mitigate some of these issues. Now, as you can imagine, in addition to high gradients, one of the drawbacks for valve-in-valve TAVR is the Russian doll effect. Marty alluded to this, but definitely, it limits future transcatheter procedures, not just valve procedures, but perhaps even coronary procedures, and especially in younger patients, that is challenging. This is just in from, I think I read this yesterday, so it might have been in JACC earlier this week, where this is a propensity match analysis on what happens long-term. And certainly with TAVR, valve-in-valve, the initial data up to a year or so is very promising. And then I was fairly surprised to see these curves start to separate out and continue to separate. Now, obviously, this is retrospective data from the French registry, and we can spend some time perhaps in the discussion section on why this might be. But at least it gives me some pause that this decision on what therapy to offer to our patients has to be on a case-by-case basis with an individualized approach and a shared decision-making. So the certain anatomic subsets that I want to take people through just with some case examples are these. So TAVR and SAVR, TAVR and TAVR, TAVR with BVF and homograft, and then some other more crazy cases. So here, for example, is a case from just last week in our practice. It's a 93-year-old 27-millimeter Hancock II. She presents with severe AI, but is otherwise pretty functional. And when we look at these extreme age patients in valve-in-valve and generally with TAVR, my biggest schema on assessing who's a candidate is whether these patients are dying with aortic valve disease or whether they're dying from aortic valve disease. And certainly age in itself is just a number. So if aortic valve disease is their only problem, then we're very happy to offer TAVR to them. Obtaining operative report is key to make sure that we have the correct valve size. And then I'm sure most in this audience, if not all, use the valve-in-valve app. This gives you an idea of what the true ID is, what the height of the frame is for any given valve, and then what the valve sizes are. Now, towards the right of this screen over here, you can see the CT analysis. And you can see that even though the ID here measures at 24, it's a little bit under measured, and the true valve size actually looks even larger. And certainly the sinuses are quite nice and large. So in this particular case, we chose a 29 valve, despite the valve and valve app recommending a 26 valve. And the key point that I want to highlight here is that regardless of what any app might tell you, what any CT might tell you, multimodality imaging and clinical judgment at the time of the procedure is key. Just as a side note, for most patients in our practice for valve and valve or self-expanding prosthesis, turns out to be an initial option, and mostly because I feel that the gradients with self-expanding valves are better in this subset. Here's another case. This is a 90-year-old with a very straightforward TAVR. The usual comorbidities: severe coronary artery disease, stage 3 kidney disease, and a perimeter of 81.1. What could possibly go wrong? And here's a self-expanding prosthesis. You can see the panel on the left. Perhaps we're missing the left coronary cusp. On subsequent imaging, we didn't think so. And after the valve was released, we had a fairly significant amount of leak. We were being a bit judicious with the contrast, so this actually is underrepresenting of the amount of AI. And in this particular case, given the amount of CAD, I was nervous leaving this valve in just as it is. We ballooned it. There was no change, and we decided with a valve and valve. In this case, this was a Sapien 3 that was within this prosthesis, and this patient got an excellent result. We actually, we're up the minimalist approach initially. We actually ended up putting a TEE probe down. We're always prepared to do that. I think this was one of the one or two cases that we did use a TEE probe, and an excellent result on the right panel after the Sapien valve. Here's a third case. This is a 75-year-old with a history of AVR with a 21 millimeter BioCore in 2010. This patient generally did well after surgery, although she states that she never really got great. And I was able to dig down an echo right after surgery, which showed elevated gradients with a peak of 54 and a mean of 34 right after her surgery. And it's important to go back to the source imaging, both the surgical report and what the gradients are, to try and assess what the problem might be. And in this particular case, it was pretty clear that this was a chronic patient prosthesis mismatch. So even though her current gradients now are higher, it is hard to imagine that putting in a transcatheter valve would significantly help this patient unless we did some sort of modification of the prosthesis. So here's the obligatory valve and valve app and the CT. Which again shows that it's a pretty small ID, and that's why this patient had all of those symptoms. So in this particular case, we chose a 23 Evolute again, and you can see on how that valve is underexpanded. And not only that, this coupled with the ID is not going to leave this patient with a good result. So our plan again was to go with a BVF, which is a biological valve fracture. This is just a reference slide to say that, number one, not all valves can be fractured. So there are some that in bench testing are not that amenable to fracturing. And our general technique is to use a true balloon with a valve size that is 1 millimeter greater than the surgical valve. So in this particular case, this is a 22 millimeter true balloon, and you can see a very nice expansion. What you can't really see is a fracture of the valve ring on this particular projection, but this patient left with a mean gradient of 4 or 5 after, and did quite well. This I think I did about a year ago. I actually say September 12th, so about a year ago exactly, and she has continued to do well. Now here's another complex case going on the spectrum. So this is an 82-year-old female with a stenotic 21 millimeter Edwards pericardial valve. She's very frail. The BMI is 20. You can see that the valve and valve app would recommend 23 Evolute. But what is quite concerning here is the low takeoff of both the left coronary artery and the right coronary artery, as well as the sinuses that are not that big. You can see, for example, that the right coronary sinus is only about 27 millimeters, and the sinuses themselves are effaced. So we're very concerned, obviously, about the risk for coronary obstruction, which tends to be about 6-fold higher in these procedures compared to a native TAVR. And then the need for further modification of the valve, given that her original valve size was quite small. So this particular patient got a right basilica with a 23 Evolute, and with a BVF with a true balloon, and had an excellent result, and actually went home the next day. And then finally, the one other subset that I want to talk about is what I think are some of the most complex cases, which are degenerated autografts and homografts. So this is a 48-year-old who had an original bicuspid valve and coarctation of aorta, has had 4 prior sternotomies, 1 for the coarc, and then underwent a bioprosthetic AVR at age 20, and then underwent a Ross at age 35. I don't really know why they chose a Ross, except that he's a very active lawyer, so he wanted to avoid anticoagulation at all costs. In fact, even when he was in heart failure, he was going out running. And now he has severe AI from his Ross due to a ruptured leaflet in the non-coronary cusp, resultant LV size now about 6.5 in class 4 heart failure. So the concerns in something like this would be proper valve sizing. What would be the correct valve? Proper placement. Where is the annulus? Where is the fixation mechanism? Since there's hardly any calcium on the leaflets and there's a flared LVOT, that becomes a challenging scenario. And you can see that this is fairly hostile anatomy. The coarc is repaired, but it still adds some complexity to the case. And even though you could see here that these sinuses are nice and big, perhaps even aneurysmal, but that likely is not where the true anchoring of this valve is going to happen. The anchoring might have to be done at the level of the anastomosis. This is a CT. I put this Tremencio up there to tell you to not always trust anything that you don't see yourself. This was the report that came back to us from our industry partners with a perimeter of 71.4, an area of 399, which would suggest either a 23, perhaps a 26 S3, or a 26, maybe a 29 Evolute. But that turned out not to be the case. So here's some procedural stuff. You can see that we're trying to define the annular plane. You have severe AI. And then we actually ended up balloon sizing it to go back with the theme of multimodality imaging and on-table assessment of all the data. And this is with a 25 millimeter balloon. And we felt that to get a good seal, we definitely would need to go with a larger valve size. In this particular case, we felt that a balloon expandable valve was going to be better. So here's a 29 Sapien 3. It looks very weird because you're not positioning it in the sinuses, but you're actually positioning it lower than sinuses at the anastomotic site. And we got a pretty good result. This patient was again able to go home the next day. This is his post-procedure aortogram. It's one of the wilder ones that I've looked at. It looks like the valve is sitting in the LVOT. In fact, we actually got a CT about a month or 2 later. I think we did this in May during the COVID pandemic, mostly because he was getting so intensely symptomatic. Before I show you the CT, here's what happened to his hemodynamics, and that's not at all uncommon in failing bioprosthesis, especially with AI. They get better quite quickly and quite remarkably, and feel better. Here you can see his CT scan, and you can see where the transcatheter prosthesis is situated. This is the sinuses here, and then these are where the anastomotic site is. Now let's talk a little bit about the risk for coronary obstruction. I had alluded to that. So there's definitely a much higher risk for coronary obstruction in certain subsets of valve and valve TAVR. Obviously, the primary mechanism is occlusion by a dislodged leaflet. Sometimes in cases where the surgical valve prosthetic leaflet itself is avulsed, that leaflet can, despite good sinuses and despite adequate heights, that leaflets can act in unpredictable ways. Mostly this happens right away, except that in a third of cases, it's a delayed presentation with hypotension and EKG changes. It's definitely not a subtle presentation. And the best way to mitigate this is a CT scan, looking at the CT scan yourself, assessing the angiography data that most of these patients will have, and then looking out for the valve types that are more prone to this. For example, the mitral flows and other valve types where the leaflets are mounted on the outside, the low coronary heights, the shallow sinuses of Valsalva, and then the CT predicted VTC, which is the virtual transcatheter heart valve to coronary ostial distance. And if that is low, then be very vigilant of this. So take-home messages then valve-in-valve can be safely performed in most anatomic subsets. The long-term durability remains an area of ongoing investigation, certainly as we move to the younger population on what is, we individualize on what is the best strategy, whether we should start with a surgical valve first, a TAVR valve first. Careful planning is key. Always obtain the surgical op report. Use the valve-in-valve app, but trust the CT. CT gives you a lot of information on not just the procedural planning, but the valve sizing as well. Use multimodality imaging to your advantage. Don't always trust the app, as I showed you in that example before. In our practice, we are always considering BVF in pretty much all cases to optimize, if it is possible to BVF them, but especially so in patients with smaller surgical valves, those less than 21 millimeters or so, and then those with a higher residual gradient on the table. Most of the time we'll use a self-expanding valve, but in certain subsets, certainly balloon expandable valves are reasonable options. And then watch out and plan for coronary obstruction. I thank all of you for your attention.
That was a great overview. Just in the interest of time, I know some people have to leave. I think we're going to move forward, if you don't mind, unless anyone has a quick comment to our next speaker, just because we're running a little bit behind, and I think some people have to leave.
Yeah, thank you, Saurabh, and also thanks Saibal for accepting our invitation at the last moment too, because we had some difficulties in editing the program with the pandemic times. Thanks for accepting in spite of short notice. I think Sushil, Saibal said he's okay to talk after you. Once your talk is over, then TAVR talks will go over, then Saibal will go to mitral valve talk. Is it okay, Sushil? You can finish your coronary protection talk.
Okay, sure. I just want to make sure that if there's issues, I can always skip mine, but I can try to do mine quickly here.
But this coronary protection in TAVR is quite relevant to our Indian patients, and we do see some procedures are done in younger patients also in our country. This is important for our Indian colleagues.
Absolutely. So let me share my slides here. Okay, can you see my slides?
Yes.
Okay, so it's a little bit of a broad topic. It's management of CAD as well as prevention of coronary occlusion. It's not showing okay?
They will adjust.
Oh, I see.
Thank you.
Okay, sorry about that. So, in coronary disease, we have a lot of randomized data, stents versus catheters, but this is one area we don't have randomized trial data. People have tried to do randomized trials, but they've been sort of unsuccessful. What we do know is coronary disease is present in about 50% of patients with aortic stenosis. These are obviously the randomized trials. In the high risk, much more so, 50 to 60 to 70%. But in the low risk patients, less. But part of this is selection bias. Patients enrolling in the low risk trials, if they had a lot of coronary disease, we tended to send them for CABG AVR. So I don't think this is truly reflective of incidence of CAD in younger patients. We know that residual CAD impacts longer term outcomes post-surgery, especially in younger patients. So we inherently believe in treating CAD. However, the data regarding the impact of CAD on outcomes post-TAVR has been conflicting results. Some show worse outcomes, some show no difference. But what we have seen with several studies, and these are all retrospective, is that incomplete revascularization results in worse long-term prognosis, especially in those patients with depressed LV function. There's two questions that we need to answer when we're looking at a patient. Does the patient have significant coronary disease? And if so, should it be treated before, during, or after TAVR? And in terms of what do we consider significant? One, is it causing symptoms, or is it really causing angina? Two, is it stable disease or ACS?
To call this severe or moderate. And if you don't do this, you tend to overestimate MR. Another way of approaching it was the tiered approach, which was used in the QUAC trial, where they took 6 criteria. But what they did was, the most important was, if your ER was greater than 0.3 or you had pulmonary systolic reversal, it was considered to be severe. If you didn't have any of the two, you additionally required a vena contracta or a regurgitation fraction of volume, or you can at least have 2 of these 4 major criteria. So what is important is that for MitraClip, also for MR assessment, it is important to do multiple criteria. Now here's an example of a patient with LV dysfunction requiring, and you can see here, this is the patient who was considered with severe MR, creatinine of 2.2, who was hypoxic in cardiogenic shock with a creatinine of 4.5, not responding to any medical therapy. And you can see if this echo displays, you can see this patient has torrential MR. And if you look at the 3D end face view, you can see that there's almost a large gap in the middle of the valve, on area of malcoaptation, which is potentially the cause of the severe MR. So this patient was taken for a MitraClip. And interestingly, we did not have to do any support, other than inotropes. There was no balloon pump, no impeller. The transeptal puncture is critical, so we do the bicable view in short axis. And this is for teaching. It should be in the mid fossa and posterior, and the puncture height should be greater than 4 centimeters. In this case, it was 4. And then we proceeded to doing a puncture, advance the catheter. Once you're inside, you have to orient the clip. The clip is oriented correctly, just to make sure that it's perpendicular to the line of coaptation of the leaflets. And then we grasp the leaf. The next part is grasping the leaflets. It's important to use 2 views, bicommissural view and LVOT view, and watching the leaflets on the clip, then closing the clip. And then you can see there's residual MR on one side. Now, usually what I do is, in addition to just color flow, I always have a left atrial pressure, the pigtail catheter in the left atrium, measuring the left atrial pressure. And if I see a reduction of airway pressure, we keep the clip. And then you see we're putting the second clip right close to it. And then you can see after the second clip, there's still some residual MR, but definitely less. So this we landed up putting the third clip. When you, of course, between every clip, you make sure that the gradient is not significant. And so you put a third clip in, and now the MR is much less. And if you see, this is what we ended up with, is you can see that the entire medial part of A2P2 has been closed. He has a large lateral orifice, a smaller medial orifice. This is what it looks like at the end, just one tiny jet here, one laterally, one through the clip. And this is the fallout. The patient came off inotropes immediately, actually, and actually was discharged home without inotropes in the next few days. And this is potentially where the therapy can occur in patients who are extremists. With this, I'll just show you an example. This is the pulmonary vein flow. You can see the systolic reversal in both the pulmonary veins, upper right and left. And then post-procedure, you can see that there's no further systolic reversal of flow in both the left pulmonary vein and the right pulmonary veins. This is the gradient. You can see it's actually stayed still at 2, which is quite good, even after 3 clips. What I didn't show is the pressure tracings. Usually the pressure tracings are pretty dramatic, but I'm going to show that in one of the next cases. This is just an example of a case of Pascal, a patient who had a failed aortic valve repair after surgery, post-surgical, had worsening AI and LV dysfunction. So he underwent a TAVR for severe AI, and then I followed it up with enrolled the patient into the Pascal trial, And then you can see over here, this patient has got a very low ejection fraction, restricted posterior leaflet, and a wide jet. The valve area was adequate, which is greater than 4. This was about almost 5 square centimeter. But you see the wide jet over here. So we decided we're going to use 2 Pascals in this patient. And the Pascal is slightly different. The puncture site should be similar. In the bicable, it's mid fossa. And in the short axis is posterior to gain height. We then put 1 Pascal, and then we put a 2nd Pascal. And I actually want to show you you can see the clasp going down in this one, clasping the leaflets. And you can see it's a much larger profile compared to the clip. And then you can see at the end, there was just 2 small jets. And the gradient was 4 or 5 at the end of the procedure. This patient, of course, did quite well. Another example where you can do this procedure, another device available for treatment of functional MR. This is what a Pascal looks like. It's a much larger profile device. And you can see over here, these are both the devices opened up and closed. And you can see what the center is the spacer. But I would like to end with this case, and there's a reason why I'm showing you this case. And this is one of the case. The next case is a case we did in India. I was involved in the first 12 cases done in India, actually all the 12 cases. And this is the case we did with Dr. Sai Satish. This gentleman came, and Sai, you can correct me if I'm wrong, was an 80-year-old gentleman who complained of severe shortness of breath, and he couldn't lie flat for 8 months. His creatinine was 2.5. He had coronary disease, severe LV dysfunction, severe MR, multiple hospitalizations. Dr. Satish requested a compassionate use of did an extreme good workup. The son was pretty well-to-do and ultimately paid almost $30,000 to $35,000 to have imported the clip. So I reached in Madras, I think on a certain Saturday or Sunday. And then there was a famous doctor from Mayo Clinic, comes and examines him and says, potentially, I think this is all lung disease and you won't benefit from this. So the son got very skeptic. The father, who was 80 years old, who was never lied flat for 10 months, said, look, I'm comfortable sitting up. It's okay for me like this. I want to do it for my children. It's all right. So he was ready to give up and do nothing. I had to convince him. I examined his... I remember I did a physical exam. Satish, you're right? It's something...
8 o'clock in the night, Saibal.
Huh?
8 o'clock, you dragged yourself.
8 o'clock in the night. Yeah. That's right. And then I examined him and I said, you don't need an echo. The patient has a loud holosystolic murmur. This patient is singing. So we just had a transthoracic. We didn't have a T. Am I correct about that? Yeah. We didn't have a T, and we took him the next day. He had already paid the money. So we said, look, it's my... We took him to the cath lab, and this is what we see. Now you can see over here, this is what I saw, a posterior leaflet which is very restricted, anterior okay, and very wide jet. But what is most concerning is there was this wide gap between the 2 leaflets. And so I wasn't even sure we could actually do this case because it's actually a wide gap. This goes against our teaching. And they had only 1 clip. They didn't have the XT. They only had NT. So we go there, and this is, I think we have a nice, beautiful picture. See that there's the orifice is reasonable size, but a very wide jet. And over here you can see these, by the way, these images were done by Dr. Chandrasekhar. And you can see there's no coaptation of the entire posterior leaflet from the medial to the middle, right there. So I was actually thinking this is actually almost an exclusion. But anyway, we went ahead and did this procedure. And you can see over here with 1 clip, we just did 1 clip. The MR went to mild to trace. You can actually see a nice double orifice, and it brought down the coaptation very nicely right in the middle over here. And at the end, this is what you get, a beautiful bow tie appearance over here. The gradient is only 2 millimeters at the end of the procedure. And what is most dramatic is the LA pressure. Look at this. The LA pressure V wave was 86 with an LA pressure of 40 on a respirator. And immediately after it goes to 21 and the V wave is only 31. So there's a triple reduction of the V wave. And this patient, of course, did well. And then I said, I wanted to find out how the patient is doing. And I want you to read this. This is him I think before discharge. This is what he wrote as a text message to me, which is pretty impressive. Read this. He said that you did a mitral procedure on my father. I want to thank you from the bottom of my heart for what you and Dr. Sai Satish have done. Before, he couldn't sleep at night, even after taking tablets. He was dysmic, his legs were swollen, even after taking 80 milligrams of Lasix per day. Now he can sleep all night without a sleeping pill. He has a little bit of swelling. We give him Lasix. There's absolutely no breathlessness. His resting heart rate is down from 95 to 80. Sir, this is a miracle. His memory has improved. His kidney function has improved. His creatinine is down, and he can walk at least 15 minutes without getting breathless. You've given him a new life. I think you don't need an echo to summarize the effect of this MitraClip. And that's what I want to end with this slide. And this is the slide that I actually showed when we presented MitraClip for approval in India. With that, I would like to say thank you.
Saibal, that's a wonderful talk and a great sort of, bringing it back to the clinical experience. Are there any comments, Sai, or?
Yeah.
Especially Dr. Grube. Why isn't Grube making a comment? That's a nice bandit.
Because, obviously everything that Saibal said. There's one good thing, though. After he is the absolute king, pope, and I don't know what else for MitraClip, I'm glad that I put a thorn into his thigh, and he will remember one day. It is actually looking and listening to him. There's absolutely no question. Look at this shitty grin he has now. How wonderful of a man as physician he is, together with all his followers. And there's absolutely no question that we're doing well. And, if you have something like this as a response, this is what we are there for as physicians. Still, that doesn't prevent me from thinking a little bit ahead. And Saibal, I don't really, particularly not after, India has approval. I think there's no question. There's no question that, you need it. My problem with that, and Saibal hopefully can confirm that, if you make the clip too easy and everybody thinks you can put a clip in, we will see a lot of clip patients with either insufficient or not, results that are not so good. And remember, it is a irreversible procedure. Once the clip is in, unless Saibal develops, a knife or something that you can take the bridge out, or a clip that is that you can reverse a clip. Having said that, there's no question that this is a treatment that will stay. And everything that comes, and for me, Saibal, and I hope you would at least in part agree, even though it might be difficult for you, the clip is there to stay, no question about it. However, let us not forget how much experience this man put into this. And there's a lot of things that you simply cannot teach. You can teach many things, but there's still a lot of experience that you have to put in. And if you don't do a good clip, and if you don't have or tooth clips or something, then I'm not sure whether you're doing the patient a favor. And unfortunately, my view is a little bit different, not about the clip now, but I don't think that the clip will resolve our mitral valve problem. And that's all I'm saying. And hopefully, at least in the morning hours in California, he's not hopefully fully awake. He could at least partly say a few nice words about me.
However, how are you? No, I like just pulling a leg. You know that you're right. You're right. Absolutely. Actually, whatever you said is all correct. Everything that you said, starting from the fact that if you put a clip in the wrong patient and do it wrong, you may actually do worse than what you did, right? If you actually distorted the valve, left with now regurgitation of both sides and caused mitral stenosis, then you've actually made the patient worse. So that's why case selection is critical. Number two, if you put a clip in, you also reduce the chance of other forms of repair or replacement, transcatheter at least. Surgical, yes, but not transcatheter. That's true. Even though replacement hasn't been turning out to be that well for functional MR, for degenerative is different. And then third, that training. I do agree that this is not a walk in a park, and you have to be very good and facile, not just in doing the procedure, but actually selecting the right procedure for these patients. I've just shown you selected patients. There are a lot of patients who, Sushil, you agree, that we would not get to do a clip, right? Leaflets are calcified, distorted, rheumatic heart disease, in India, rheumatic heart disease, or post-inflammatory. This won't work. So MitraClip is only one form of repair for a group of patients. And therefore, I think I should have ended with that MitraClip is probably best suitable for the right patient in the right hands in the right time. That should be my...
One more thing. Thank you very much that you're so kind of me. It's probably the morning hours. There are two things, actually. One, which case you would choose for Pascal or which for clip? Or will there be another fight like between core valve and balloon expandable valve? And the second thing is, your perspective on, having a restricted, we know now, and as Scott reported on that, even in primary patients, you do well, even if you don't do so well with the mitral regurgitation reduction. If you leave a patient +2, for example, and you will see some patients, if not many, with leaving the catheter with more than 2. Does it impact? So impact more than 2, great. And the second choice, Pascal and clip.
So I'll go first with the second part, Pascal versus... I don't want to fall into trouble by what I said last time in TCT about the two devices. But all I can tell you that I was named in both the lawsuits. So I'll avoid making any comments about which is better than the other. Just saying they're both good patients. Okay, so they are both good devices. However, I have some concerns about Pascal in India. And for the reason is because the valve sizes in India are smaller, and the anterior-posterior diameter of the valves in India is slightly smaller, which I found when I did cases in India. In fact, I'm not even sure that you need the XTR in India. I think most cases in India can be done with NT and NTR. That is, to me, the interesting part that I think, which one of the 12 cases that I've seen. So that's one of the concerns I have of Pascal in Indian patients, because it's a longer arm and it's wider. So that's why I still think that MitraClip at the present moment, with a predominant use of NT, not the XT size, longer arm, will be okay in India. So that's one thing I would just say. Regarding, what was the first question you said about
leaving the cath lab more than +2? Incomplete result or not a good result?
So I think most people leave. I don't think you get trace MR in most cases. I think most people are left with 1+2, 1 to 2+, right? And what we have to look at is when we deploy the clip, you have to see, is there a reduction of MR and is there a hemodynamic change? If I see an LA pressure that dramatically comes down, as in this patient, the V wave coming down by more than double, and there's a reduction in LA pressure, then I'm actually very satisfied. The color jets don't matter to me. Because what the patient sees is the LA pressure. If you see an MR reduction and then you see the LA pressure is flat or it's gone up, or the gradients become 6, then you're doing it a favor. And that's what I always do, as he knows, I always have a pigtail catheter in the left atrium while I do the procedures to understand what are the hemodynamic changes that take place with every implantation of a clip. If I put a clip in and I see 2 jets on either side, and I see a dramatic reduction of the V wave, I'll say it doesn't matter what the color flow looks like.
And that will continue to get better, right? The initial drop may continue to improve over time. As you sort of bring the leaflets together, then they tolerate medical therapy more because they have better forward flow and all those things too. So I think
Today we're talking about LV dysfunction in MR, where it's a different subset of patient.
Yeah.
But let's say we're talking about a primary MR, a DMR
Yeah.
patient,
Yeah.
right? There our goal is a little bit more different. Our
Correct.
goal is to bring the MR to 1+. Again, we don't get it always. But if you can bring it down and you start seeing that there are a lot of changes that are taking place. The elevation is coming down. The pulmonary vein flow has improved dramatically. Even if you have a few jets on either side, I think it's fine.
Thanks, Saibal. I think this is a wonderful discussion. I think we're going to move on to the next section. I think actually Ajay wants to say a quick word, and then we're going to move on to the next session. And I'll skip my first talk in the next session, interested in moving things along. Ajay, do you want to say something?
No, I just want to say it's a phenomenal presentation and great discussion. But as Eberhard said, and it's great to see you, by the way, Eberhard. We do love you, even if Saibal didn't. But as yeah, you too, Saibal. I think it's really, really important, though, with this procedure in particular, because of how safe it is if you just apply this to everybody, there are a lot of people who can deploy a clip and it's done safely. The patient does okay for the short term, but you really haven't benefited the patient. And you really need to work with this procedure to get expert at it and work with your echocardiographers to not just get in and get out, but to take the time to make these patients better. And if you do, you're going to get emails like the one Saibal got. That's all I want to say.
And but you're right, but it's not, the problem, like TAVR is one component, interventionist. Here it's the imaging component, but the heart failure component for functional MR, and you're working as a team to say it's the best thing for the patient, then you're working as a team to do the procedure in the most expert way. And it requires really, truly building that team.
Yes, medical therapy is a very important. Yes.
Can I ask a last question about the Saibal's talk? So is there there is a lot of discussion about the COAP trial, and we have pushed aside the MITRA-FR because of its own issues. How does it compare this data of COAP with the TVT registry? Because we don't talk too much about the registry, and that's what we are discussing here, that in real life, the situation is different. And we have to.
So first of all, I have a paper in consideration right now in European Heart Journal, which is a big deal, where I actually said, if you look at the MITRA-France trial, very detailed, it wasn't a bad study. Well, number one is they had no safety issues, right? Even if they were less severe. And two is that if you look at the 2-year data, there's actually a separation of curves of heart failure admissions. So I think that if you put both together, it does favor, at least you see, if you said, okay, you did a clip in patients with less degree of MR, it's like angioplasty. If you do it in, like Ajay, in patients with less than 50% lesions, you wouldn't show benefit, but you may cause harm. But you didn't cause any harm. So that means the MITRA-CLIP, if you put them all together, that it is safe, but if it's done in more severe degrees of MR, then you benefit from it. Now, the TVT registry is a mixed bag. So that's another example to show that you didn't always select the patient. The COAP trial, we were, of course, very rigorous with our case selection. That's why you got such good results. If you followed, I still think that you don't have to be rigorous. For example, cardiogenic shock, the patient that I showed, that was an exclusion of COAPT. If we had more cardiogenic shock patients, the mortality benefit would be even more greater, right? We took stable patients. What if we took patients which are unstable and then treated them?
You're absolutely right. I think there's a lot of patient selection that goes into this.
Yeah.
Thanks again, Saibal, for early morning doing this. Although it looks very bright there, very early in the morning. I'm not sure.
It's in my bedroom. I'm just got out. I have to go to the farmer's market.
Well, enjoy the rest of your day. Thank you again.
Thank you.
Thank you. All the best.
Thank you, sir.
Thanks all the panelists and Eberhard and everyone, Praveen, Sai, and everyone else on the panel for a wonderful session. I know we're running late. So I'm going to move on to the next session. Ajay, do you want to start off and take over? And I'll skip my first talk on tricuspid because I think we're about 2 years away from that talk being necessary, at best case scenario. So,
Sushil, we have some case presentations in between Indian experience. I'll skip mine, and I requested RKJ and also to skip. We'll briefly have presentations by our colleagues or guests Sai Satish, Ajay Swami, and Praveen Chandra. We have these case presentations of Indian experience. They'll each of
Okay.
them finish in 5-6 minutes. Then we'll go.
Yeah, so Srinivas, why don't you moderate and you lead the discussion so we know what needs to go when. But it's a pretty exciting session of a variety of different topics that we don't normally see.
There are actually so many questions also came up for Saibal because the MR stuff is quite common in our India. Anyway, I can discuss with him later. So I request Dr. Sai to present his case and request them to stick to time because we are running much behind the schedule.
Srini, I'm going to start my timer.
Please.
Okay.
Sai,
I'm starting mine as well because I don't trust you.
Sai, thanks for those slides, by the way.
You're welcome. You're welcome, Saibal. But it was a beautiful presentation. It's always such a pleasure to be here in the same room with all of you. Can you see my screen?
Yeah, we can.
Okay, I'm going to fly past this. I call this series some of my most gratifying cases, and my timer starts now. Sushil, you can double check on me. Sri, thank you for the opportunity. You kept me riveted to the screen all this while. So here goes. First patient, 64-year-old man, morbidly obese, asthmatic, severe AR for over 10 years, gradually worsening, finally planned for TAVR in December, presented with shortness of breath and had a cardiac arrest in the ER, hugely dilated LV, 9 centimeters, severe AR, unable to ventilate him as lungs were too wet. You can look at the echo, huge LV, 9 centimeters, heart is hardly moving. I've treated this man for 10 years. I've known the family. All my patients are quite dear to me. You can look at this TAVR protocol. It was done in May 2018. He qualified for a 29 valve. He waited for his children to get married, to see grandchildren, for his dogs to have puppies. And by the time he came to me, in October 2019, he had moved to a 34 valve. So hardly any calcium, huge LV. I had anatomic challenges going in. You can look, even with a single Lundaquist wire, the nose cone was buckling. I had to actually put a second Lundaquist wire into the LV. Second Lundaquist wire into the LV, got the valve across, and no matter what I did, the valve wouldn't stay even on a still heart. It would either jump out or it would dive into the LV. And since I was so pressed for time, I thought the best thing to do was drop the first valve, 34, let it go sit where it's going to sit because the mitral valve is so far away because the LV is so dilated, and then snare it and use the first valve as an anchor, put the second valve in a better position. So this is what happened, working during CPR in between CPR cycles. So the first valve is in place, first valve is held, second valve is in, everything is released, and that's the final result. Good seal, not much leak, patient did extremely well. This is day 1. This is day 3, that's day 5 at discharge, and this was him wishing happy Diwali. 1 week later, he's doing really well. So that's 2 minutes for the first case. I'm going for 2 minutes for the second case. 63-year-old man, severe AR, severe AS, mild AR, severe LV dysfunction, EF 25%, was admitted with heart failure, got quite sick by the time I got to him, tachycardia, hypotension, systolic pressures, 70 to 80, barely holding on, surgical turn down, transcript due to morbid risk and poor access. So the right side, the femorals are 4.4 into 4.4, and if you look at the left side, there's something really nasty happening at the common iliac bifurcation. They actually want me to do this case subclavian. These are the subclavian images they sent me. But when I went and took a root angio, took a pigtail shot of the access, I felt I could get away with a transfemoral. Second of all, he was looking so sick. The last thing I want to do is do CPR while the patient has got a subclavian access. So anticipation is key to doing a TAVR and getting away. So you can look at the tachycardia, pressures were 60, 70 systolic, and great position with the valve, but everything starts going south at 85%. The heart starts slowing down, pressures bottom out. I have almost no pressure. So at this point of time, I'm thinking, what's happening? I recapture the valve, and I start getting some pressure. The cardiac activity starts returning. Do my quick checklist, my hypotension checklist, but now, as you can see, backing out is no longer an option. So we have the people ready for the CPR. As you can see, again, deploying the valve on a still heart. I want you to notice the guy with 2 rings on his arm, and then I want you to notice the guy with no rings, no watch, And you can see I like to take a small puff when this happens, so I don't have to worry about where the pigtail moves with the CPR. And I have a good visualization. I can go ahead and deploy my valve on a still heart. So working between CPR cycles, the valve is in position, everything is removed, CPR is continued. So again, look at the CPR. You have guy with no rings, guy with watch, guy with no watch. So we had enough people waiting to give CPR as long as it was needed. Intracoronary adrenaline, everything we could think of. Finally, mean gradient 6, no AR, and the iliac survived beautifully. And this is the patient 12 hours post-implant, and day 5 he went home. Okay, and the last case, 86-year-old man, post-CABG, severe AS, moderate AR, severe MS, severe MR, MVA with planimetry was 1.2, refractory heart failure, planned to fix the aortic valve because there was severe MAC, frail old man, morbid risk for surgery, EF was 45%. And these multi-valve cases are really tricky. Things can go south very quickly. You can look at the axis. The left side was really bad, 3.1 into 3.6. Right was okay. This is the anatomy of the annulus. So use the right radial for the pig positioning. You can look at the mitral annular calcification. And he was quite sick on table, even with the anesthesia, took the pigtail shot. And even if you're really quick, you get the position right, you very quickly open the valve, this can happen. The CVP shot up on table, patient arrested. The key was, again, to have somebody there giving the CPR, and CPR, some more CPR, and finally 30 minutes later, pressures pick up, CV starts dropping, mean gradient 6, trivial AR, MR looked much better, he was extubated the next day. So almost no situation is unsalvageable in a cath lab today. Planning ahead and anticipation account for 80% of work towards outcomes. A good understanding of imaging, echo, CT, and fluoro, meticulous attention to detail, pre, peri, and post-procedure is a recipe for reproducible, predictable, and excellent outcomes, even in the most unfavorable of cases. And that's 6 minutes, 8 seconds. Thank you all so much.
You are on time. I had 6 minutes on the dot. So it's impressive set of cases. A lot of CPR going on. I mean, I think your point is that the cases are salvageable, but you have to be prepared going in. Go ahead, sorry.
Most of these cases, you have a fair idea that things are going to go south. And the most important thing is to fix the mechanical problem. So you have to have your team ready for CPR. You have to have your anesthetist who's great, and you have to focus on what you have to do. And anticipation accounts for a lot. That's what I was trying to say.
Yeah, no, I think that's an important point. And I think, managing hemodynamics up front is key. So, some of these patients, in the hospital, have them on inotropes, optimize the hemodynamics to the point you can, diurese them, get them in the best hemodynamic shape possible before the procedure. And then we also, with our anesthesiologist, have them give a little epi, like small doses, just to get before the valve crosses. Because especially in these patients, once the valve crosses, you stent open that leaflet and you get severe AR and you get this ischemic spiral. So we try to get them, they call it resuscitation, just before they arrest, before you get the valve across, or you try and maintain a higher pressure and a higher pressure hold. Right. And what you've discussed is, quickly just making a decision. Don't go for perfect position in these cases. It doesn't matter if it's 6 or 2, right? And so don't go for perfection. Deploy the valve and get a valve. And I think are the key components. But a nice example of very tough cases and salvaging a good result from all of them.
So, Sushil, can I make a comment about your first case, your severe AI patient?
Yes, I do.
When I do this evidence for AI, I tend to do rapid pacing through the entire cycle. Can you hear me?
Yeah. So cycle crystal clear, but the patient was already in the cardiac arrest.
No, I'm saying that, remember you said that you had done multiple, it was going either in or out.
No,
that you said even on a rest it was going.
Yeah.
Even on a rest it was not.
Even on a still heart, yeah.
Okay.
As long as you don't conclude that all my patients have cardiac arrest, I'm happy.
You're not giving us any evidence to the contrary.
But what Sushil was highlighting was that if there's a way to prevent such problems, always do it and rather than landing it. That's what I think. We had
Absolutely.
similar experience, but because of his experience, we could avoid patient going into that problem. We would immediately deploy it and patient came out. Anyway, now we request Dr. Ajay Swami to go for his presentation. Giddy Grandi Tower and Post Resuscitation. Again, resuscitations. Just now we saw some. Ajay, we request you to be brief.
Absolutely. I promise I'll be as short as possible. I wonder if my screen is visible.
Yeah.
Crystal clear.
First of all, I thank you to Dr.
Make it full screen.
Srinivas.
Make it full screen.
Is that better?
That's okay.
Yeah. So I must first thank Dr. Srinivas for giving me this opportunity. I know I'll take up 20 seconds.
Yeah, still you can go for the full screen. There is a button below on the left, lower left, third button. If you press.
Are you seeing this now?
Below that, lower left, third button.
Yeah.
Small. Yeah, there. That one. No.
Okay.
Here. Right. That's fine.
That's fine. Right. Dr.
Yeah.
Saibal, I remember you taught us how to put the LA appendage occluder, the watchman.
Yes, I remember you.
And great to speak in front of such
Great to
stalwarts.
see you too.
Yes, absolutely. This is the case of the giddy grandfather. We are very fond of, naming our cases like that. So this is the story of a 66-year-old man who collapsed while in the ENT OPD, visiting the hospital with his grandson being evaluated for giddiness. The code blue team was called, and after 10 minutes of CPR, they managed to get some rhythm, put him onto the ventilator, intubated. Cardiology consult was called for because they heard a murmur. And a bedside 2D echo showed severe LV systolic dysfunction with an overall EF of 20% with global hypokinesia. He had severe aortic stenosis with a peak gradient of 65 and a mean of 43, even with this LV function. Repeated attempts at extubation, he could not be extubated. So the plan was to do basically at stepwise a palliative BAV plus a CAG, then extubate and then see further and see whether we could actually get him off the ventilator. And that's what we did. This is our first attempt. We went in and did a BAV with an 18 millimeter ZMED balloon, and at the same time did an angiogram. And this is what his angiogram was like. This is a CTO of the RCA and the circumflex, but the LED is flowing fine. The RCA is big and it's a dominant RCA. So post BAV he improved. He could be extubated the same evening. The pH normalized, his BP stabilized, could be taken off inotropes, and at the end of 2 weeks, a heart team discussion took place. We discussed it with the surgeons, and they weren't really very keen. And we spoke to the next of kin, took a high-risk consent, and did a staged CTO PCI for the RCA. This is a bilateral injection. We were very careful with the femorals, so we used only one side, the same side that was used for the BAV, and then went ahead and did the CTO RCA. I know we're short of time, so I'm going to rush through. Basically, this was a straightforward CTO with an XTR and a Gaia, and then a wire placed at the distal RCA. And you can see that we had done the LVED at the beginning, and this is serial dilatation with NC balloons and finishing off with 2 long stents. Got a decent result under the circumstances. And again, after a month, because his LVED was very high at that time, we stabilized him a little bit more, 2 weeks, 3 weeks. He still continued to be in and out of hospital, but at the end of 3 days of intensive IV diuretics and other supportive care, we managed to take him up for a TAVR. He was a bicuspid valve with a little bit of a horizontal aorta, so some challenges in delivering the valve, but there wasn't a problem. We just had to put another wire into the pigtail, and we were able to deliver the valve and finish off the procedure. No CPR done, Dr. Sai, I'm sorry, but we managed to get away with that result, and we accepted it, and it actually looked very well, 40% at that time. And when we did the follow-up echo at the end of a month and a half, LVAF was 40%, gradient was down to 4. He now walks 2 millikilometers daily with no giddiness. The take-home messages from this case: all giddiness is not vertigo. All arrests are not only coronary artery disease. And for a successful result, especially in complex cases, teamwork is essential. This is the work of 6 weeks, over 6 weeks for this one patient. And planning and preparation are key to success. We don't plan to fail, but we often fail to plan. Thank you. And I think that's 2 minutes. 1/3 of what I'm excited.
Thank you, Ajay, for being saving some time.
Count on an army man.
Yeah,
either saving lives or saving time.
Yeah, army is like that. We request now Dr. Praveen Chandra to present his transcatheter TAVR approach. As we heard from Marty, that if you can do femoral approach is good, otherwise patients become high risk, but he has experience with transcarotid access. Sir, please be brief. We'll go to the next session soon. Thank you.
Thank you, Srinivas, and I thank the faculty sitting here, which is such experienced faculty, for being here for such long time now. I'm sure they must be tired sitting, so I'll quickly finish my case. And so this is transcarotid access, which we have started doing everywhere, and this is the data which is showing from various registries that the transfemoral access is still the most preferred access. But the problem is that we cannot do it in every case. As we see patients, more complex patients are coming up, and we see that femoral access is not available or it is not possible. So what are the approaches? So there are so many approaches which can be done, but out of these approaches, we have to select which one we can use and choose to do in a particular patient. So what is the data on carotid access? So this is the data from France TAVI registry from 2013 to 17. And in here you see that a large number of patients were done through various approaches. And in this, it was found that the 92% were femoral access and about 7.5% was transcarotid access and rest were transsubclavian. And the results were found to be similar in comparison to femoral approaches where transcarotid access was compared. The TVT registry data again showing a similar thing, that out of 100,000 patients from 2015 to 18, and this was presented in 2019 last year, about 500 patients underwent transcarotid access, and they found less mortality, less AF, less vascular complications, and less stroke than the transaxillary or the transapical approaches. So which means it is a reasonable approach, and in our small series, we have done some subclavian, transcarotid, and a transcaval access also, and we found, let me show you one of the cases, how did we do it. So this was a patient who is 86 years old, female patient, and had a severe aortic stenosis. So everybody was like quite confident that this should be a good case for TAVR. She never had any investigation. She was so scared to come to the hospital. So the only time she came to the hospital was to start with the CT angio and then do the procedure on the same hospital admission. So she got admitted, and we found everything positive in her and sent for a CT. But as soon in the evening when the CT came, I got a message that probably will not be able to do it tomorrow. And the lady was scared. As you can see here, that the femoral access on both sides are really quite bad, and the rest of the things are quite okay. The valve looks good, and so we were quite positive that the once we are able to reach the aortic valve, it should be all right, and there is no other complication. And in here you see that the whole aorta and also both the femoral arteries were badly calcified, and you can see the abdominal aorta is quite bad. And this is the terrible, and on the right side and the left axis is also quite bad. So hardly any trying to go from the femoral approach. And this is the picture. You can see it is almost coming to 3 millimeters on both sides. So which one should we choose? So we got the images quickly back to the CT room on the left subclavian and the left common carotid. And here you see that the left subclavian was also having a narrowing at the origin. And here you see that the vessel is quite small sized and there is a calcific chunk at the left subclavian origin. So we found that was quite clean and reasonably good in size. So we decided to go with this carotid access, and just to carotid access, as you can see here, we go with an open dissection. And the good thing about carotid access is that our vascular surgeons and our cardiac surgeons both are very, very comfortable doing this. Generally, it is quite a routine procedure for them. So this part becomes quite easy. So they give you access immediately. It takes about 10 minutes to do that for them because carotid artery is quite superficial and is quite a nicely accessible artery. So once that was done, the carotid access was achieved. We immediately, when you can see that the carotid artery is so nicely visible here. And once the artery is completely under control, here you see that the artery is so clearly visible. Then they just do a small puncture here with a needle and put a 6 French sheath, and then we start on. So this is on the left carotid access, and we are standing on the left upper end of the patient's side. So this is how the whole situation little bit changes, and the screen goes onto the right side. So that's the vascular access, and then once the vascular access is done, then in this case the problem was that we were not able to put a catheter from the groin, so we had to go from the right radial axis. This is the sheath you can see has been put into the carotid arteries, and from the right radial we put a coronary angiogram was done, and after that we tried to put a pigtail, but it was completely stuck up. So we just left a wire inside, and the first angiogram was done from the carotid axis for the aortic root. Once the angiogram was done, we knew the coplanar view, and then the wire was put with the from the right radial axis, as you will see here, that this is the radial axis for pigtail, and we were not able to take the pigtail inside because that was also quite tortuous and calcified. So the only thing which could stay there was a wire. As you will see here, this is the wire which is going inside uh, the aortic root. So that will be our guide during the entire procedure. So we are putting the wire here, the wire stays inside, and this is how the wire is positioned. You can see that the wire is positioned here into the non-coronary cusp, and after that we then start taking the crossing the valve. The valve was crossed, and through the carotid approach you can see that we are trying to cross the valve. This is the AL1 catheter. The valve will be crossed slowly, and once the valve is crossed, we then change it with a heavy duty wire, and the valve which we have chosen is a self-expanding valve, Evolut R, because in here, as you can see here, that we never had any experience with any of these valves earlier. So we thought, let us do this because this is the most severe calcification, in those patients, we go for a non-transfemoral TAVR. And in the transcarotid access, we have found that the patient acceptability is very good. We have seen no patient with stroke, because that is one of the concerns in everybody's mind. But doing a low down cut open and doing a procedure like this generally helps quite nicely. And we got successful results in all our patients. Thank you very much.
Thank you, Dr. Praveen. Human body appears to be great in spite of us. It tolerates. And only thing is probably you can image carotids before and to avoid the plaque presence there.
I can't hear, Srinivas.
Okay. Increase the sound. Can you increase? Thank you, Praveen.
I can't hear.
Can you hear me now?
We can hear you, sir.
We can all hear you, Dr. Srinivas. We can all hear you.
Yeah, okay. That's what I was mentioning. We did have some experience in newborn when we did ductal stentings with the pediatric colleague Nageshwar Rao through carotid. We used to access it. Newborns also, some of them used to dramatically become pink. We have good remembrances of transcarotid, but now I think TAVRs are also being done. Thank you very much for all my Indian colleagues for showing excellent cases. Now we move on to the last session. Actually, this is the last very hyped up session of our meeting. I promoted it so much so that a lot of people were interested, but unfortunately, we had to push it. I kept it in the end because to keep the interest. And I'm happy that because of this also maybe still so much of interest. This is what gives me happy. 1,800 doctors are still on, let me tell you. And I will also share you who is the doctor who has a maximum time who are logged in the end. So thank you. With this, I request Dr. Host has to leave. Thank you very much. Can you get Dr. Host share the screen, please? Dr. Host Stewart, sir, is always a big support right from early start days of TCT. And we have very fond, good remembrances of his case presentations and techniques. Whenever we had some issues, we always discussed. And we had some experience with the son too in our place. And thank you, Dr. Stewart, for joining you at the short notice too. It's an honor to have you. And we are looking forward to hear you regarding your stroke intervention work.
Thank you very much. Thank you very much for the invitation. It's really a pleasure to be back in India in some India at least. So you asked me to talk about stroke interventions. And the title of my presentation is Acute Stroke Intervention, Why, When, and in Whom, and by whom. So really the breakthrough in technology, how we treat acute stroke had been the stent retrievers, which are inserted via a microcatheter. So we cross the clot in the middle cerebral artery in this drawing here with a regular wire, like a whisper wire, for example, or a synchro wire. Then we introduce a microcatheter, and through that microcatheter, we introduce one of these stent retrievers, which is a very flimsy and very soft structure, and this expands into the clot. And after waiting a couple of minutes, we are able to retrieve this together with the clot and put it back into the guiding catheter. So this is the way how the stent retrievers work, and they really have improved a lot the results of our acute stroke work. Another system which I'm very often using in combination with stent retrievers is are the aspiration catheters. This one is from Penumbra, but there are others available as well. These are 6 French catheters which can be advanced up to the level of the middle cerebral artery, very soft and very fragile, and they are able to aspirate big clots from that area. So a couple of years ago, 2015 and 2017, there had been 9 positive randomized trials, and they showed that lysis plus thrombectomy is clearly superior to lysis alone in these large vessel occlusions. Large vessel means internal carotid artery, middle cerebral artery, as well as in basilar arteries. We learned that time is really brain. In each minute, we lose about 1.9 million neurons, 14 billion synapses, and 12 kilometers of nerve fibers. And the subgroup analysis of these trials performed in 2015 show that if we can reopen a blocked artery within 2 hours, then recovery rate is 90%. And if we are able to do this in 6 hours, the recovery rate is only 20 to 30%. So really time is brain. And if we can remove the clot within 1 hour after stroke onset, really most patients recover on the cath lab table. Well, who should do it? Ideally, a comprehensive stroke center, trained neurointerventionalist, 50,000 procedures minimum, 30 years of training in invasive techniques, 20 CML courses per year, on call every night in a team approach where neurosurgeon, neuroinventalist, neurologist, psychiatrist, physical therapist, and vascular surgeon are all at patient bedside in the ambulance. Obviously, this is our highly trained neurointerventional team, so you can imagine this is not something which can be done. So some statistics from the US, and the same applies to... Can you still hear me?
We can hear you, sir. Please go ahead.
Some statistics from the US and similar statistics are from Europe, and I'm sure in India, there are 800,000 strokes per year in the US. 200 neurointerventionalists are working. That means 4,000 strokes per year per neurointerventionalist. Not all of them will need an intervention, but all of them will need an interventionist on call. But there are more than 10,000 interventional cardiologists, radiologists, and vascular neurosurgeons who could actually help and support them. Cardiologists, as you well know, are almost everywhere. They have the infrastructure for emergencies. They have a cath lab. They have staff. They are on call anyway, and they can and have to be involved in acute stroke interventions. So just show you a case example. This is a young girl who suffered from a stroke, 16-year-old girl, lives in a small village close to Frankfurt, goes to high school, 10th grade, would actually like to study medicine, but she's not sure that she can make it due to the grades. On Tuesday, August 11, 2015, that was her destiny day. So in the evening of that day, she suffered from a sudden weakness of the right of the arm and followed by complete hemiparesis. She was still awake but could not speak anymore. Her mother, with the help of neighbors, managed to bring her to the emergency room of the St. Catharina Hospital where I'm working. Yet complete hemiplegic at the time of arrival, could not speak. CT still showed normal findings, which is important because when CT shows something, then it's usually too late. CT angiogram showed left middle cerebral artery occlusion. Door to lysis time was 22 minutes, so very fast, but no clinical improvement. And there was a discussion with the mother about the options. Neuro called me at 10 p.m., a big stroke, 16-year-old. Can you help us? Transport from the patient to the cath lab. At that time, she arrived a couple of minutes later in the cath lab. And this is the angiogram of the middle cerebral artery. And you can see that this vessel is occluded. We do all these procedures without anesthesia because we don't want to lose any time. This is 25 minutes after the initial stroke call. And you can see a whisper wire inside of a microcatheter in front of the middle cerebral artery occlusion. And this is after deployment of the stent retriever, even before clot removal, and you can see restoration of flow. And that is very important because even at that time, before you have removed the clot, very often you have a restoration of flow, so the brain can recover to some degree. This is the clot which could be removed 33 minutes after the initial stroke call. And she said, "Ich kann wieder sprechen," which means I can speak again. So this is 45 minutes after the stroke call.
Jetzt die Hände so nach oben stellen, Augen zumachen. Ich kann jetzt nicht weiter
So as you can, cannot advance. So as you can imagine, this was complete recovery. If nothing else comes across, probably 60 to 70 additional years of a normal life instead of decades in a wheelchair. So the key points here are in acute embolic stroke, embolectomy, in addition to IV lysis, if indicated, has become the treatment of choice. It's a class 1A recommendation. It can and should be done up to 6 hours after the onset of symptoms, and in selected cases, up to 25 hours. But every minute counts, time is brain. Cardiologists therefore can and should become involved. How to learn acute stroke interventions? Well, you have to read the literature. You have to get some initial experience in angiography of supraaortic vessels. Learning how to do carotid stenting is very helpful. Attend carotid stenting and stroke courses like our ICCA stroke course. and then simulator training and observation in the big stroke center, and then, of course, ongoing evaluation of procedural outcome. We have founded a society which is actually helping with that kind of training. We are organizing proctorships in centers who want to learn this. So if you are interested, just send me a message and I will make connections. Thank you for your time, because time is brain. Thank you very much.
Thank you, Dr. Sivat. That's an excellent talk as usual. And I'm happy, I think, to mention to all the cardiology colleagues across the country that recently, many times, they were worried if you do stroke intervention, whether it could be medico-legal problems happen. Recently, European Society of Cardiology and Interventional Cardiology Society of Europe, what you call EAST or something, got recognized now. Now, the recommendations-wise, cardiologists are also, interventional cardiologists are also eligible to perform stroke intervention. Correct me if I'm wrong, Host. I think it is recently announced by European Society President too. And that's a good news, not to worry for cardiologists.
Yeah, that's true. And there will be a paper be published probably within the next month, which explains how to get involved.
Thank you, sir. And we'll be always happy to coordinate. And one of our juniors in Apollo, Dr. Ramakrishna, and many others are also getting trained. Now in Apollo's emergency, the stroke protocols gets activated faster than acute MI protocols. So that's how there's good work going on. It's required for patients. That's why I'm very passionate. Right from the beginning of TCT, we were having stroke intervention sessions. Thank you, sir, for your time.
Can I ask Horst a question?
Yeah, you are the host. Please.
So, these trainings and, I guess the wire skills and everything, do they translate pretty well from coronary to cerebral vasculature? Is it more about learning the anatomy than anything else, or are there wire skills and all those other things that take time?
I mean, this is a different procedure, and there's for sure a learning curve. But when the most difficult part is really to get access to the carotid. So if you have some experience with that, then it's only a small step. And when I started doing these kind of interventions, I thought, I have to learn all these branches and all this. It's actually not the case, because we are treating the proximal parts of these vessels. And we are not interested in the distal branches so much. Of course, you have to learn it, but it's not something, when you start learning this, it's not more difficult than learning a CTO or TAVR or MitraClip. It's something you can learn without being in a neurocenter for 2 years. So that's over. That's not necessary.
And in your experience in the centers that are doing it, are they doing it combined? Obviously not everyone in the interventional cardiology group needs to learn a skill set. Are centers creating like 4 people in the hospital, whether they're interventional cardiology or neurointerventional, that take call, or a certain number that as a group take call, or how is it being operationalized?
It's very much very similar as with all other procedures. So when you start a TAVR program, you will not teach 10 doctors at the same time. You will start with 1 or 2, and then you can expand. And when you open a interventional stroke service in a stroke center which does not have that before, it's not necessary to start with 24/7. Because if you just provide it initially during the day, that's fine. Of course, the final goal is to provide it all day and all weeks. But initially start slowly and then expand. When you have more experience, then you can go for night shift and offer this also during night. That's better than doing nothing.
Good point.
And another for the logistic and admission and various other obvious financial reasons too, what we have decided is we keep the patient under neurologist. Anyway, they have to have neuro evaluation too. And we deliver the goods and we do the procedures a little fast and still continue to be under follow-up with neurologists. That's a biomedia which we chose. And we have a good interventional neuroradiologists too now, and some of the cardiologists are also getting trained. That's a good news for us. And I think we are behind. We'll go for we have identified one more neurointerventionist also, sir, for the talk. He'll do it at the end. Anyway, the next is Sushil was kind enough to avoid his talk. Anyway, we are not there yet at tricuspid valve. Now I request my good friend, Dr. Rajendra Kumar Jain, Director of KIMS Hospital here. Always a support. The endovascular session here was also coordinated and designed by Dr. Jain. And another interesting news also I'll share with him later. Now this BRT therapy or therapy in chronic heart failure patients, vagal nerve stimulation, is just got US approved even in US. And Jane has maximum experience when we were part of the trial. And that's how I requested Dr. R.K. Jain to share his experience and tell us about this new therapy in heart failure. Both you, Dr. Jain. Can you connect Dr. Jain's slides? See your still picture, Jain. Hello? Are you there? Yeah. Go ahead.
Yeah, my hi, good evening, everybody. I think all of you had a wonderful tower session, and I can see the whole galaxy of the top cardiologists of the world. So I'm very happy to share some of my experience with this new therapy. My slides are visible?
No, not yet. Share the screen. I think you didn't do it. Yeah, they're coming up. Okay. Make it full screen.
So I would like to share a little experience with autonomic regulation therapy for improvement of left ventricular function and heart failure symptoms. And we are part of this trial, Santam heart failure study. And we...
You make it full screen. Click on the button below.
So I made it full screen.
Yeah, now you press that.
Now?
No, that left button. Press that. It's not becoming. Okay, we can still see it.
Sir, enable editing is there, no, sir, on top. Can you please click that?
Enable editing.
No, that is for modification slides.
No.
Isn't productive.
Look for, when you go to share screen, look for new screen share. Look for new screen share, identify your presentation and click on it. Then it will work.
Now?
No.
Now it's fine.
Now it's fine. It's fine.
Okay. So we were part of this clinical trial. Along me from India, we were Dr. Kamal Sharma, Sanjay Mittal, and from US, Dr. Indar Anand and Dr. Badri Amrutar were the part of the study. So this study was sponsored by Cyberonics Houston, USA. The background is, as all of us know, autonomic imbalance in heart failure is by increased sympathetic activity and withdrawal of parasympathetic activity. And this autonomic imbalance is associated with progression of heart failure and worse outcomes. Preclinical and clinical studies suggested that electrical stimulation of vagus nerve may restore autonomic balance. And most of the neurologists knows that left-sided VNS is commonly used for epilepsy and even right-sided VNS. So an attempt to know that left-sided VNS, which could be combined with other devices like CRT, has not been evaluated in heart failures. And we wanted also to see the effects of the left and right-sided VNS have not been directly compared. So this was an objective of this Anthem heart failure study. This was an uncontrolled open label study to evaluate new autonomic regulation therapy with right or left VNS device for treatment of patient with chronic symptomatic heart failure with reduced ejection fraction. The objectives were feasibility, tolerability, and safety of this ART system. And the primary safety endpoint was incidence of procedure and device-related adverse event during the 9-month duration of the study. The primary efficacy point is a change in left ventricular ejection fraction and left systolic end systolic volume at 6 months. The secondary endpoints changes in 6 months at left ventricular end systolic diameter, 6-minute walk distance, quality of life, Minnesota Living with Heart Failure Questionnaire, New York Heart Association class, heart rate variability, and blood biomarkers like NT-proBNP and highly sensitive CRP. The Anthem Heart Failure Committee, the steering committee was headed by Indar Anand, Independent Data and Safety Committee Gary Francis, Independent Statistical Analysis Thomas Rector, Echocardiographic Core Laboratory Dr. Srinivas was in charge from Care Hospital Hyderabad, and the sponsor is Cyberonics. This study was entirely done in India, and these were the clinical study sites from Vedanta, Sanjeevani from Ahmedabad, Narayana Udalaya, Madras Medical Mission, KIMS, Yashoda, Sengupta Hospital, Nagpur, Pune, Goa, and Care Hospital, Hyderabad. The inclusion and exclusion criteria were patient with stable symptomatic heart failure with class 2 and class 3 only were eligible. Ejection fraction should be less than 40. Left ventricular end diastolic diameter more than 50 and less than 80. QRS width should be less than 150 milliseconds. And patient should be on optimal pharmacological therapy for at least 3 months. Exclusion criteria: prior cardiac transplant, any degree of heart block, primary autonomic dysfunction, refractory symptomatic hypotension, any severe restrictive lung or obstructive lung or restrictive lung disease. The study design was interesting. Once you have informed consent, the patient is randomized to either left side VNS or right side VNS. Once the VNS device implant, and this is done by our cardiac surgeon colleagues who got trained, and patient was given 2 weeks of time for the healing of the device and the healing of the wound, and the VNS system was activated. Once the VNS system activated, the titration was done over a period of 10 weeks. Once the titration is complete, the patient's cyclical VNS therapy was given for 6 months, and the outcome measures were measured at the end of 3 months and 6 months. So the safety and adverse events assessment was done over a period of 9 months. So this is the device used was VNS therapy system from Cyberonics, Houston, Texas. More than 1 lakh implants have been done left-sided in epilepsy patients. So it can be done by a surgeon, cardiac surgeon, or any other neurosurgeon also. It has to be implanted on the left or left-right vagus nerve by the surgeon, and there is no RV sensing lead in this. And the main goal of this this device was chronic intermittent stimulation delivered to vagus. 10 Hz natural frequency and 250 microsecond pulse width was used. The VNS intensity was titrated over 10 weeks to maximal tolerable current below the threshold of side effects or heart rate change. So you can see in this graph, and this is how the VNS therapy is done on and off here, 14 seconds on and 60 seconds off. And when it was on, it was given 10 megahertz and 250 microsecond pulses were given. A continuous ECG was done at the time of stimulation to see there is no acute heart rate changes. Over time, the side effect threshold gradually increases, and the average stimulated current is 2 plus minus 0.6 milliamperes. So these are the screening, enrollment, and follow-up. 78 patients were screened, 60 were randomized because of exclusion criteria. Some had a death and some withdrawal. And right side implants were 29, left side implants were 31. During implantation, 1 patient died because of the embolic stroke. Then the titration were 29 and 30. And 2 patients died during follow-up, and there were heart failure deaths and sudden death. They are not related to the device. The baseline characteristic, if you see on left side and right side, are similar. And these are pooled data. Males were more in this number in this patient. And if you see end-systolic dimensions were 51 and not more than 80. The blood pressure was normal, and there was no ICD implant in any of our patients. And if you see the standard of care, 100% of them were beta blockers, 87% were AS or ARB, and 79% was on aldosterone antagonistic. Digoxin was in 32 patients, loop diuretic in 88 patients. So that means most of the patients were on good medical background, medical therapy. That's a beauty of this study. If you see the serious adverse events, related were seen in 21 patients, 1 patient, unrelated were seen in 20 patients, and 1 was post-surgical death, and 1 was heart failure death, and 1 was unrelated sudden cardiac death. Non-serious AVs were 19, like in the form of voice alteration, hoarseness. 13 patients had a cough. 8 patients had oropharyngeal pain. Implant-related infection, none of them had. System malfunctions, none of them had. There was no therapy discontinuation by patient or PI in any of the patients. If you see the primary efficacy endpoint, the left ventricular ejection fraction didn't improve any of the patient, but there was a trend towards the improvement in the left ventricular end systolic volumes, even though the confidence interval is more, but there was a trend. So these are secondary efficacy endpoint. If you see left ventricular end systolic dimension improved, the p-value is not very significant, but the patient had a dramatic improvement in class of symptoms. The patients from 24 of the patients who had class 3 symptoms became class 1 in 30 of the patients. So that was a dramatic improvement with the p-value very significant. The 6-minute walk distance was increased by 56 meters, and this was also significant different. Minnesota Heart Failure Score Index also minus 18%. This was also significant. There was no heart rate variability. The heart rate didn't change. NT-proBNP change was not significant, and other parameters like CRP was not changed in this group of patients. The limitations of the study was the uncontrolled and open label. Placebo effects may be contributed to observed changes. Although no significant differences were observed in any outcome with right and left sided ART, the confidence intervals of the most measurements are wide, some differences cannot be ruled out. This study was conducted in India and the results may not be generalized to other populations. If you compare these ART trials with other trials, like a cardiovit study and nectar heart failure study, there are also patients mostly in class 2, class 3 symptoms. The number of patients are more in nectar heart failure study when compared to our study. And this was randomized sham control nectar heart failure. And we have used Cyberonic device. This was a biocontrol cardiofit system. And here they have used Boston Scientific precision system. If you see the stimulation frequency ours was 10 megahertz and there was 20 megahertz. And cardiofit study, it is a 1 to 2 megahertz synchronized to cardiac cycle. And our stimulation amplitude also was less when compared to cardiofit fit study. Duration of follow-up was same and therapy-related SAEs were least in our study. The primary findings in our study was improvement in cardiac function and heart failure symptoms. And cardiofit study also there was improvement in cardiac function and heart failure symptoms. Nectar heart failure, there is no change in cardiac function. So conclusions, the Anthem heart failure approach to ART, chronic low amplitude natural frequency on either left or right side was feasible and well tolerated. Safety assessment did not raise any concerns. Both left and right ART were associated with improvements in cardiac function, left ventricular ejection fraction, left ventricular end systolic dimensions, heart rate variability and heart failure symptoms in the form of NYHA class, 6-minute walk distance and quality of life. Further investigation of ART in a controlled clinical study is warranted. And this is published in Journal of Cardiac Failure. Thank you very much.
Thank you, Dr. Jain, for presenting this. Now that it is accepted by US FDA, my US colleagues, probably Ajay or somebody can answer. Are you ready to take this therapy, especially for patients who can afford and having to continue symptoms who fits into the criteria? What do you feel in India? Are we there, Jain?
It is not launched yet. So they're still, I think US, they are going for another study, the same device. But this device has not got FDA approval, but the other device got the FDA approval.
But this therapy got approval, whether the same device...
Therapy got approval, yeah.
The therapy got approval and they recommended that even the guidelines of US FDA approval, they've changed slightly with the approval of the device. Need not wait till the outcome studies. So immediate parameters are changed. Something like that recommendations were there. I think they will know more better, but it's getting delayed. So now we'll go to another interesting study. Can we get Dr. Vikas Agarwal share his slides, please? Balloon pulmonary angioplasty, that is BPA in CETPH patients. We do see this subset of patients in India. So we sometimes fail to do or not knowing what to do. We do give the medical therapy with all the types of vasodilator drugs and others. But now this procedure is probably be done for some subsets of patients. And if they are identified right, they would benefit by this procedure. And we have Dr. Vikas Agarwal from Michigan to give this. He was kind enough to start this program in Apollo, and we are trying to work on it. Over to you, Dr. Vikas. Can you get Vikas on the screen?
Yeah. So can you guys hear me and can you see my slides?
Yeah. Please go ahead.
Thank you, Dr. Kumar, for the kind invitation and the kind words. And, it's my pleasure to...
You need to make it... Okay, now it's fine.
So it's good?
Yeah.
Yes. Yeah. So thank you for the kind invitation. It's my pleasure to participate in this wonderful meeting. I'm going to spend the next 10 minutes talking about balloon pulmonary angioplasty in patients with chronic thromboembolic pulmonary hypertension. I don't have any disclosures pertaining to this talk. And I'm going to try to talk about this new therapy in relationship to a case that we did not too long ago. It's a 67-year-old female who was diagnosed by our colleagues in the pulmonary hypertension program, with chronic thromboembolic pulmonary hypertension. She was initially sent to us because she had progressively worsening shortness of breath and fatigue, and by the time we saw her, she was unable to perform her activities of daily living, without assistance. Her 6-minute walk distance was markedly reduced at 210 meters. Her expected walk distance was 400 meters. And her other comorbidities included some obstructive sleep apnea and hypertension. She was already on 2 pulmonary hypertension medications when we met her, selexipag and riociguat. Her workup included a ventilation perfusion scan, which showed multiple mismatched bilaterals, right more than left perfusion defects. Her echocardiogram actually showed normal biventricular size and function. She had a right heart cath done, which showed evidence of pulmonary arterial hypertension with normal filling pressures. Her left heart cath did not show any evidence of coronary disease and normal filling pressures on the left side as well. She had a CT, chest done, which did not show any evidence of acute pulmonary embolism. However, she had evidence of some mosaicism, which is essentially a CT scan showing low and high attenuation in the lung fields at the same time, as well as diminutive segmental and subsegmental arteries bilaterally. No significant parenchymal lung disease was noted. I have to stress that these patients can often have an unremarkable CT chest because most chest radiologists are not used to looking at chronic thromboembolic disease on CT scans and can often tend to undercall them. So a negative CT scan doesn't mean they don't have chronic thromboembolic disease. So onto her pulmonary angiogram. So, you can see the anatomy on the right side, but essentially she has multiple areas of hypoperfusion on her right lung, similarly on the left lung, but the right lung is definitely much worse than the left. So she was seen by our multidisciplinary CTEPH and pulmonary hypertension team. It's very important to take care of these patients in a multidisciplinary fashion because you need someone to help with the pulmonary hypertension medication management. You need a cardiothoracic surgeon who's experienced in these. So in these cases, you need an interventional cardiologist or an interventional radiologist. You need an expert chest radiologist. And pulmonary thromboendarterectomy continues to be first-line therapy in these patients. And for a center to be an expert CTEPH center, your surgical outcomes have to be acceptable. Less than 5% in hospitals mortality is a benchmark a lot of programs use. These patients should all be seen at a center that has a multidisciplinary team like this. They all need indefinite anticoagulation, and then they all need to undergo operability assessment, meaning can they have the pulmonary endarterectomy procedure? And as with any open heart surgery, you have to weigh in their clinical syndrome, their comorbidities, and their surgical risk. And then you also have to weigh in their anatomic and hemodynamic considerations. So to expand more on the anatomic considerations, how do we define proximal disease versus distal disease when it comes to CTEPH? As you can see on this slide, you have the left main PA here, that's proximal. You have a major lobar branch to the middle and the lower lobes, that's proximal. And now you're starting to get into the segmental branches and then subsequently into the subsegmental branches. So personally, I would say if you have some disease in the proximal main PA or in the lobar branches, currently pulmonary thromboendarterectomy is the treatment of choice. When it comes to segmental branches, it depends on the patient and your surgical expertise. Some centers still prefer to do what we call as a distal PTE. However, balloon pulmonary angioplasty is also a pretty attractive option for patients with segmental and subsegmental disease. So in this case, after a multidisciplinary discussion, it was thought that she's the best managed with balloon pulmonary angioplasty. She underwent a total of 5 angioplasty sessions over a period of 2 months. So at our segment, at our institution. So the interventional approach, so we set the contrast limit for every session at 3 times the GFR. We do that for all our vascular and coronary procedures as well. The radiation limit is set at 2 grays per session. Femoral vein access is pretty much used every time. However, you could use internal jugular vein access in selected cases. We use IV heparin, so with an ACT goal of about 200 to 250 during these procedures. Their systemic anticoagulation is, of course, withheld and started after the procedure. So we like to use 6 French coronary guide catheters in conjunction with guide extension catheters for subselective cannulation in these cases. As most of you already know, we don't have dedicated guide catheters to engage the different segments in the lung. So it's sort of, it's a case by case basis. You figure out the anatomy, you figure out the shape you need. I have found using a guide extension catheter in conjunction with a JR4 that helps you change the length of the nose of the JR4, highly useful. And our goal is to treat multiple segments in each session, however, to stay in the same lung for that session, because God forbid you have a bleeding complication, you have the option of selectively intubating the other side. And we like to use workhorse coronary wires, whichever ones you like in your practice, and coronary balloon catheters for the most part. And the patient is admitted overnight. So initially, we were sending these patients to the CCU overnight. Now we are keeping them in the cath lab post-procedure unit, and they go home the next day. So for this case, we started with the right A4 segment. It was selectively cannulated with a JR4 guide and a telescoping guide extension catheter. That's the baseline angiogram. The lesion was crossed, with a Chion blue, and so I use a Navus pressure catheter as a support catheter for these cases. It's very hard to free wire these lesions because your guide is barely supporting you on most occasions, and using a pressure catheter as a supportive tool also lets you measure a baseline gradient before and after the lesion. So in this case, as you can see, the distal pressure almost looks like a wedge pressure tracing or a flat line. So this tells us that there is a significant gradient. This lesion was treated with a 2 millimeter compliant balloon, and subsequently we treated this entire segment, up and down both the branches, with a 2 millimeter compliant balloon. So that's the pre-angiogram, that's the post-angiogram, and you guys can see how the perfusion is a lot better. However, also keep an eye out for the venous return at the end. It's not playing anymore. I'll show you some more images soon. So the pre and post pressure tracing, I use my pressure catheter in pretty much every case now because it's highly useful to document arterialization of the distal pressure tracing as your endpoint in these cases. You don't have to abolish the entire pressure gradient, but if you can establish arterial flow distal to the lesion, that gives the vessel the best chance to remodel. So with flow over the subsequent weeks and months. So now on to the right A7 segment. As you can see here, this occlusion was crossed. So with the Chion blue again. I'm sorry, let me play the previous one again. And so you can see the enhanced venous return. So where my red arrow is pointing to at the end of the angioplasty, that's also a sign of successful revascularization in such cases. You don't shoot for perfection because the bleeding risk and the risk of complication is pretty high. So now the left lung, the left A9 segment, that's so you want to use a J-tip on your wire to cross these lesions as much as you can. It will minimize your chances of a wire perforation down the road. After an angioplasty here, sorry, I don't know why this is not playing right.
Okay, it's okay, Vikas, you can proceed. Okay.
So onto the left A5 segment here. So at the end of the 5 sessions, you guys can see the PA pressure came down from 48 to 31. The cardiac index went up from 2.8 to 4.2. PVR is now normal at 2.3 from 5.65, and the patient continues to have a normal GFR. Her 6 minutes walk distance improved from 210 to 341, and she reports near resolution in her symptoms of shortness of breath and fatigue, and she did not have any significant complications related to this procedure. So just for the audience, what's the best marker of adequate lesion dilatation in balloon pulmonary angioplasty? It's not the residual stenosis, it's the presence of brisk venous return in the segmental territory at the end of your angioplasty. You have to be careful because over-dilatation in these arteries can lead to perforation and hemorrhagic complications. This is a low-pressure circuit and very prone to rupture. To summarize, a multidisciplinary, careful evaluation at an expert pulmonary hypertension center is the gold standard for these patients. Always think about surgery first. If they can get the operation, they do much better. And the BPA procedure is currently reserved for those who are not expected to benefit or to not undergo surgery. Thank you for the opportunity. So my alma mater, Maulana Azad, Medical College will always be in my heart and my current place of work, University of Michigan, and Dr. Kumar for this wonderful opportunity. If you guys have any questions, you can ask me now or you can shoot me an email.
Thank you. A lot of questions could be there, but we are running slightly behind the schedule. There are questions which have come in WhatsApp chats also. But one thing I wanted to check, Ajay, do you do such procedures in Colombia?
Yeah, we do actually, and I have a very similar observations to the ones that that were made over there. So it's a great overview. I think that you have to be careful in terms of how you do it. Personally, I've adopted some CTO type techniques and equipment in terms of microcatheters and trap liners for certain cases, but for the ones for the most part, you want to take softer wires. You don't want to take hydrophilic wires for the most part to do these cases, and you have to do them carefully. But it actually can be a pretty rewarding procedure. But the most difficult thing is to assess the pulmonary angiogram of all the branches and tortuosity, because it's very, very different than what we're used to in the coronaries.
Yeah, I always think of patients who do not have appropriate therapy and still suffering. And if we can relieve 50% of the patients, improve with this also, it would be a good addition apart from the medical drug therapies. I think now we come on to the last and important talk. There's a lot of interest coming up on renal denervation, and Medtronic is planning to launch. I think it just got approved on a compassionate ground in our country, and we are trying to see how best we can use this. And let us hear about this from Ajay Kirtane, and he was a part of this newer trial which is done in US. So that I thought it was the best person to talk about it and also advise us how to proceed initially in selecting these patients of RDN. Over to you, Dr. Ajay.
Well, thanks so much. And I'll try to keep this brief and in the time taken. And we're going to talk a little bit about how this has been revisited because it's been visited in the past. I think just to set the stage, it's pretty clear that despite the fact that we have many medications for blood pressure is still a massive killer in terms of both cardiovascular and cerebrovascular events. And despite the fact that we have these medications in many places, control is very, very poor. What's interesting about this slide is a quote-unquote developed world, but frankly speaking, when we look at things like COVID-19, there's not much difference between many of what we call the developed world and what is not the developed world. And in fact, I would say we're less developed, certainly here in the US, in our response than many other places, including India. So I find it somewhat interesting when it's presented with certain slides. That having been said, several years ago in 2009, we basically had a situation where we had a first initial case report of renal denervation in a patient with 7 antihypertensive medications whose blood pressure was reduced. And with that came the promise of renal denervation as a therapy. And many are familiar with the story. I'll sort of take you through it very quickly because I want to show you more positive data. But initially, there was a large randomized trial that was thought to be going to lead to U.S. approval. And this initial trial basically came out to be negative. There was no difference between renal denervation with this initial version of the Simplicity catheter compared to a sham control. Blood pressure dropped in both groups, but there was no significant difference between the two groups. So the real question that came up is that we saw this New England Journal case report. There were other reports throughout the world, but yet why couldn't we show this in a randomized clinical trial? If this was efficacious, then why did Simplicity Hypertension 3 fail? So I think there's several reasons for it. The first is that there's a variable distribution and density of the nerves. And so one of the things that we were initially taught was that we could ablate near the origin and so as to get the ganglia, but that's so deep there that you can't actually achieve that. And it turns out that the nerves travel closer to the artery the more distal you go. And so it turned out that we didn't know this. Much of this data was proprietary at the time these trials came out. And had we known this, we might have focused more efforts more distally. In addition, what we knew from the initial catheter or RF catheter that was simply monopolar was that we were kind of randomly hitting the nerves in this type of cyclical pattern. And this is even an optimized version because the patients are breathing. It's a 2-minute ablation. We're moving the catheters. And so it's actually surprising that any effect was shown at all because of almost how stochastic or random these ablations were over time. Now, the other thing that was shown with subsequent data is that the more nerves that were ablated, the greater the reduction in renal norepinephrine, and therefore that was tied to a reduction in blood pressure. And so if we don't get all the nerves or we don't do it circumferentially, then we're not going to be getting an effective ablation. Beyond that, though, there are also trial design elements that change things. And so first, this important trial design element of the fact that 40% of patients change their doses of medications during the trial meant that even if you do a large trial, the signal-to-noise ratio is limited because there's a lot of noise if patients are going up and down on their medications. And so even if you have a signal, albeit a weak signal, at least with the initial iteration of the device, it would be hard to show a benefit overall. Finally, the last part I'll mention is that with any clinical trial, simply by being in the clinical trial, oftentimes a parameter like blood pressure improves. The CORAL trial was a trial of renal stenting. What you see within this trial is in both groups from baseline to 3 months, there's a significant reduction in blood pressure, almost 15 millimeters of mercury, just by being in the trial and being absorbed more closely. So if you start seeing this effect, how do you measure an effect of a therapy in addition to that? And so what basically happened after that point is all of these issues were approached and optimized, not only the procedure, but also the way we did the clinical trial to be able to sort the differences out. So for one, we looked at blood pressure via ambulatory blood pressure monitoring, and we also did a stable baseline. So patients were washed off of medications or put on a poly pill so as to get a stable reading at the time the actual randomization was done. We additionally optimized the catheter. So for instance, the Medtronic catheter I showed you before was optimized further to form a spiral catheter with a potential helical ablation pattern, more ablations, and the procedure was optimized with more distal ablations as well. And then finally, as far as the drug changes and adherence were done, we basically did trials off medicines completely or on a stable dose of a poly pill. So what happened when we did that? Well, first, this is the off-med pivotal trial that Medtronic ran and was presented at the ACC and published in the Lancet. Basically, patients were washed off their medications and randomized to renal denervation versus the sham control. Patients were followed up every 2 weeks, and at 3 months, the primary endpoint was assessed, which was a change in ambulatory blood pressure. After that point, medicines were started and 6 month and beyond assessments were taken. This is the catheter that was iterated. This is the catheter that allows a wire to be placed through the catheter, and then the catheter is advanced to a distal position, the wire is removed, and ablations can take place in this helical pattern. The procedure was optimized. Rather than just doing 4 ablations in the main vessel, the procedure is now into the distal branches as well, because that's where the nerves are closer to the arterial lumen. And by doing it this way, this is the primary endpoint results, basically showing a significant improvement in blood pressure with denervation compared to a sham control. And these are ambulatory blood pressure measurements, so a change of approximately 5 is typically going to be associated with a reduction of 8 to 10 millimeters of mercury in office blood pressure. Here are the individual curves for what happened over the 24-hour cycle. And with renal denervation, you see there's a reduction in blood pressure compared to the sham control, which really doesn't change over time. And this is always on, in the sense that it's not just on when you take the medicine. Because it's a procedure, it's always on throughout the entire day. And that may have potential benefits in terms of outcomes once those outcomes are looked at. In addition, medications, escape medications, while these patients are off medicines, were much more frequently employed in the sham group compared to the denervation group. And overall compliance was pretty good within the study because this was studied somewhat assiduously. Now, there are other technologies as well. This is the RECORE system, the Paradise system, that looks at a single balloon with ablations circumferentially within the main artery. So you don't have to go distally because it affects the circumferential ablation with a cooling balloon to protect the lumen so there's no adverse events. Very similar trial design to the Medtronic design in the sense that patients are taken off their medications, they're assessed for eligibility, and then randomized to denervation versus a sham procedure. With follow-up to 2 months, we could see reductions with denervation, 8.5 millimeters of mercury compared to sham at 2.2. And these patients actually receive medications. So in fact, if you do it in a per protocol analysis, you can see the reduction is 8 to essentially 0. In addition, there were more patients controlled off medications with denervation compared to sham. One of the interesting things we did with this study, just like with the Medtronic studies, but we've reported this data so far, is that when at 2 months patients were seen, they remained blinded and the physicians remained blinded. And what you did is you added back medication to see if you could further control patients' blood pressure. And what you see is that there are more medications added back in the sham arm compared to the denervation arm. And despite the fact that more medications are added back, the reductions in blood pressure are greater numerically in the denervation arm compared to the sham arm. So if you adjust for these medication differences, i.e. more medications with sham, there's a reduction in blood pressure with denervation compared to sham. So here's the sort of graphic depiction of it. At baseline, the blood pressures are the same. At 2 months, this is pure, basically placebo effect in this arm. This is the denervation effect here. And then as medications are added back, there are more medicines added back in this arm, but yet blood pressure still remains lower with denervation compared to sham. Finally, the last trial I'll show you is the spiral trial on medications. So these are patients who remain on medications, hopefully steady state of medications, and assessing the difference between denervation versus sham. And there's a reduction with denervation compared to sham with the spiral catheter, with increases over time. This is despite the fact that medications are changing a little bit, and this is suggestive of the fact that because the procedure has been optimized, we can overcome, in a sense, this noise and still show a treatment effect. Finally, for patients with resistant hypertension, these are patients with elevated blood pressures despite the fact that they're on multiple medications, you can see pretty profound decreases in ambulatory blood pressure with either the Medtronic device as applied to the branches as well as the main arteries, or the RECORE device in terms of the ultrasound, and these differences are not significant, but certainly it's better than just applying the Medtronic device in the main vessel. In other words, you have to go distally. That's for the RECORE device, you tend to stay proximally, and the question is whether this can be maintained over time. Here's the meta-analysis that we recently published of the trials, and even including the first generation trials with these non-optimized designs, non-optimized procedures, there is a reduction of blood pressure seen in ambulatory blood pressure monitoring with denervation compared to control. So just to conclude, what's the target population for these therapies? Because as these therapies get approved, we're going to figure out who should be getting them. I think it's important to recognize that adherence to medications in a real-world setting is actually pretty poor. This is a really interesting study where urine was sampled, and among patients that were supposedly taking medications, this is the percentage of prescribed drugs that were actually taken when you sample patients' urine. So despite the fact that you may prescribe a medicine and you think the patient's taking it, oftentimes they're not, and they may not be taking it as you suggested. So the authors concluded that in detecting non-adherence in clinical practice is almost impossible. This should be assumed, and therefore what's really important is just to look at the blood pressures. And if the blood pressures are poorly controlled, then those might be patients who are candidates for denervation. But not everybody is going to have an effect. This is an interesting study looking at arterial stiffness. And as arteries get more and more stiff, the proportion of patients who are non-responders goes up. So clearly you need to have a sympathetically mediated cause to your hypertension. There are certain subjects of patients or subsets of patients for whom this is going to work better. Patients, perhaps more central adiposity, more sympathetic activation, those are the ones who are going to respond. This is a slide that is more aspirational. Could you do denervation as an alternative lifelong polypharmacy? I don't think so. I think that the reality is that medications are cheap, they are effective, and they probably will be first line for many patients. But who could denervation help? Well, I think, number one, we have to take a step back and recognize that despite the availability, despite the number of classes of medications, and generally the fact that they're well tolerated, hypertension is a real public health problem. And there are many sources of resistance. Lifestyle is important, medical therapy is important, and are generally going to be mainstays of care. We do know that denervation has established efficacy over sham. And that's important because it means that we have an additional tool with which to treat patients. Of course, we need to do follow-up studies on safety. Most recently, in the Global Simplicity Registry, 1,500 plus patients studied for 3 years. Denervation is extraordinarily safe. So that's a good thing. We still need to follow them for longer periods of time. But I have a problem with people who say, well, don't use this at all because, we have other tools out there. If your other tools are failing, of course, educate on those tools. Of course, get more adherence to them. But you should be willing to choose any tool that would work to help this global health problem. And I think in the end, we're going to see more about emerging therapies like denervation, other therapies as well, that will have an important adjunctive role in addition to medical therapy and lifestyle modification. Thanks so much for listening, and happy to take any questions at this time.
Thank you, Ajay, for your encouraging words about RDN. Presently, what bothers us is some end-stage renal disease patients and some patients with persistent hypertension, where we are not able to control with drug therapy. That's where we are looking at. But Medtronic, what it is proposing now in India is to do it like a average blood pressure, which got response in the study. So that's where it's difficult to convince patients. What they want is now to have a middle range of blood pressure patients to be tested with this newer therapy. What are your thoughts on it? Could you hear? Hello?
Yeah, we can hear you, Srinivas. Ajay, can you hear?
Yes, I can. Say it again. Sorry, I'm just dealing with an emergency from the hospital, but go ahead. Go ahead.
Sorry. What Medtronic, what we want as clinicians is to have a solution to the end-stage renal disease patient-like patients where you have a severe resistant hypertension, where we are not able to control with drugs. But because they are worried that it may not work, what Medtronic is proposing now in India is a positive study type of patients, where you have mid-range type of hypertensions, pressures varying between 150 to 170, and some exact values I don't know, but they're not the severe resistant ones on drugs. So what are your thoughts? You feel it is a good way to start with mid-range hypertensive patients?
No, actually, I think once it's approved, the patients that are truly resistant would be a reasonable patient population to try. I think that we still need some more data in that patient population. And then for others that are mid-range, that just either don't want to take their medicines or can't tolerate their medicines, those are ones to take as well. The important thing to realize, though, with any treatment is that there is sort of this thing called regression to the mean. So the higher your blood pressure starts off at, the more effective a therapy is going to be. If you start off with somebody with a blood pressure of 145, whatever therapy you give is not going to change their blood pressure all that much. So that's just another principle also to sort out with.
I also felt the same. And with Venkatram being with us in Apollo, he was with one of your co-speaker. And he and me are trying to do this and start this therapy in Apollo. Hope it works for patients. And thank you very much, everybody, for the patient listening. And any further questions for any speaker, if you are already not tired, you want to take. There are some questions in the chat, but I would answer them because it's too much late. So with this, is it okay, Ajay and Sushil, for me to say a few concluding words? Or any
Absolutely.
Absolutely. I know it's really late there and people that are still on. So.
No, but still, I think people are interested and a lot of logins are still there. I just wanted to make some few interesting awards before we conclude. One thing was, is the COVID pandemic increasing, then cardiologists are getting more time. Some of them are not knowing what to do. So what I proposed was, this is a concept which I thought we should make youngsters more active. Rather than wasting time watching Amazon Prime and only videos at home, I thought that's okay to occasionally enjoy with family, but spending only for that and not doing any other work is a wasting time, I thought. So what we proposed is a COVID challenge for cardiologists: convert your free time to productive time. So something useful. What I said is either you upscale your skill, go for training, or at least if not in the professional era, you can do something artistically, learn some flute, music or something, which I am trying to do. That's how the flute master came in the inaugural function. So like that, then upscale your knowledge and at least publish. You have time, free time to write, which we Indians are very poor somehow. We do a lot of work, but publication is weak. And if not anything, become more healthier and fitter. That's what I was telling Dr. Bashi, the CT surgeon who presented aortic aneurysm. He became very fit and smart, and same thing. So I proposed various entries to that. We got not many, but a few, 5, 6. But out of the best, I thought, I wish I could have shown those videos. But the best I thought is the person who did all. And obviously, we were also trying to do something, but we can't take. So out of the entries which we thought, we had reviewed with 2, 3 of my other colleagues also, not because Jane is my good friend. I actually didn't want to give it to Jane because he's senior and is a director of hospital already. But the amount of work which he did is phenomenal. It's not comparable to any other entries. So what he did is he has published 6 papers, all the important ones. Of course, he has a DNB program also, and he did it with the fellows, but it is quite appreciable that he had produced 6 high quality papers in good journals. And second thing is he's lost 6 kg weight and became more fitter. And third, he continues to see some outpatient consultations and online consultations too, occasionally visits hospitals still, though its load is less. And lastly, he also learned dance in the process of losing weight. He has sent those pictures. I wish I could have shown, but it's already too late. So the COVID challenge for cardiologist winner, I request Dr. Sushil. I already told the name while talking, but you please announce. I thought Ajay or Sushil can announce that.
It's a great idea, and I think we're all trying to find ways to keep busy. And the winner is Dr. R.K. Jain, and sort of. I wish I could have said I lost the 6 kgs too, but I did not. I think I got it.
Can you make R.K. Jain bigger? And this is his winner prize, his iPad Pro, the latest version. And because he was here, I thought he would hand over, but it will reach you in courier service, Jain.
Thank you.
Thank you very much for taking interest and helping us in the program also.
Thank you, Sushil, and thank you, Srinivas Kumar.
And his advice for us, one more differently from cardiology, which we put in the intro video, was cardiology should also learn investment skills. We are very good in our professional work, but we should also know how to multiply money. He did it. Actually, now he's a multi-crorepati and millionaire also. He owns part of the hospital. That's different, but it's a good advice for youngsters. Thank you, Jain. Another important piece of award which I thought we should do, it is unbiased. I just came to know just now, is can you launch the longest login cardiologist? I thought we should give an award. Obviously, Ramakrishna, you come here. Myself and Ramakrishna, my junior colleague here who was handling the show in the other room, maybe longest, but obviously we can't take, this is Ramakrishna who helps me in hospital and most of the other things. We can't take it. So apart from us, when I asked them to check in, to what right now I am also seeing in front, and Harshita, who was managing, she sent. Dr. Ramya P. from Hyderabad Apollo Hospitals, he has logged in for 23.52 hours. I was surprised because our total program was for 33 hours and we are overlapping halls for some time. But she managed to be the most because sometimes the sessions got delayed. So we congratulate others, and I also appreciate very senior cardiologist, the Dayasagar Rao sir, also stayed in for 22 hours. Quite appreciable at that age. And others, other doctors also deserve applause. But this award, what is the award project that goes to Dr. Ramya P. from Apollo Hospitals, Hyderabad. She's a cardiologist and the daughter of another senior cardiologist. Thank you, Ramya, for being with us long. I think with this awards session is closing. I would like to just briefly mention a few words of thank for all those people who made this possible for us. Obviously, the first to be mentioned is a very good faculty, which obviously comes with the help of Sushil and Ajay and all the CRF faculty and all the international faculty. We are very much thankful. I was happy to say that even to end, about 1,500 cardiologists logged in because the program was very good. I have received so many appreciation messages. I won't go into details. All because of you. Thank you, Sushil and Ajay, for making this happen. And you also had Greg and Mati and others. Thank you very much. And apart from the faculty which you brought, all other cardiology cooperation across the country is very important. And that's how we get enthused to do more such works. And I should also mention the people who are, obviously, I can put in effort and time, but we can't put in our money too. So sponsors are important. So what I plan is generally request one of the two main companies to take care of the existing costs directly. Others we can't spend. So I should be thanking Abbott Vascular, Dr. Subodh. I actually wanted to get them in and log in, but it got delayed. I hope they will excuse us. And then Abbott Vascular, Dr. Subodh, and Lupin, Dr. Saurabh Agarwal. These two were instrumental. One was instrumental to get into the digital platform. Other was instrumental, obviously, to get into all these live case dealings and all. And next would be the Medtronic, Dr. Mr. Ravi and Vikas of Medtronic also played a significant role. Out of the pharma companies, other ones to mention is USV, which helped in organizing all the cases together and putting it in right frame so as to avoid time waste. I think many other companies who are projected also helped, and we thank all the sponsors for making this happen. And the AV digital team, a lot of my colleagues have asked, quite impressive work you people did, and Harshita is a central point of contact, that Geeta Nair and many others, CEO for the company. I don't remember everybody, sorry for that, but thank you very much for all the help. And the local team here, Mr. Jain and their team members who had projected me very well. I wished all the cardiologists who are at least from Hyderabad to come here and give a lifetime picture, but many of them were worried because of this COVID. Dr. Nageshwara or Jain were supposed to come here, but unfortunately it couldn't happen. But anyway, thanks for making this, all the AV team. And my Fax Foundation members, obviously, will be like thanking me, like Ramakrishna and my other Noor Khan and many other people who are involved. I may not be taking all names. I thank everybody for making this happen. And before I close, I thank all my cardiology colleagues across the country, all the senior faculty who logged in, helped in conducting these proceedings. And so much enthusiasm till late also gives me a lot of encouragement and a lot of courage to do such programs in future. Thank you all. And before we break, we'll have a national anthem to close. Can you have?
Can I say one comment? Can I just?
Sorry, please go ahead. Sorry.
Yeah, no, I just wanted to thank you for pulling together and everyone that's been involved. I know it's a very difficult time in India with COVID and cases ramping up, and I understand that it's challenging to do these things, and there's a lot of other priorities, and the effort it takes for everyone to do this in this difficult time. We really want to thank them and respect all of their efforts, and we hope that everyone stays safe and stays well and gets through all of this. But thank you and thank everyone for everything that you guys have all done.
Yeah, Ajay, Sushil, one more thing. When we were discussing, I mentioned to you, I'll promise that there'll be 2,000 plus logins definitely attending. It's not like any other smaller meetings, smaller webinars which you attended before. We maintain a different class and a different quality of speakers. I was very sure that people will be happy. Once they log in, they never were able to get out because of quality of lectures which are going. So many appreciations received. Thanks for it. And I wish they projected, Harshita had that slide of all the attendees every day also, but maybe it is it there, Harshita? Before we close and go for national anthem, can you project that slide? I have it. Yes. Do you have it, made?
The 5 attendees, sir?
Yeah.
Okay.
Anyway, yes. If you can do it, it's fine. Otherwise,
no, that's okay. So yeah, no, we can.
Thank you. We have communicated in the mail too. This is the now attendee number. The slide is done before, and Friday being less, but still it's good numbers. Then Saturday was the most, and then Sunday even now people wanted to have little fun, but still 2,000 plus attendees. Thank you, Ajay and Sushil, for making this happen. We'll be happy again to do anything further for educating and such programs in the country. And thank you all. We'll have raise up for national anthem. Can you put that national anthem? The sign of respect, I thought, though it is late, we should have it. No, though nowadays you have it in movie theaters too also.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all and namaste.